Yes, hello, check. Hello, hello. টেস্ট হ্যালো টেস্ট হ্যালো 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 টেস্ট হ্যালো টেস্ট হ্যালো 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 টেস্ট হ্যালো হ্যালো গেছে হ্যালো 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 টেস্ট টেস্ট 1 2 হ্যালো টেস্ট হ্যালো ঠিক আছে ওকে ক্লিয়ার নয়েজ আছে কোনো হ্যালো টেস্ট 1 2 টেস্ট 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 হ্যালো হ্যালো টেস্ট হ্যালো টেস্ট হ্যালো 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 টেস্ট হ্যালো 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 শিখলো
Recording in progress.
হ্যালো হ্যালো ওয়ান ওয়ান টু ওয়ান টু আচ্ছা একটা ক্যামেরা একটু অন করে দেন হুম level লাগাইতে হবে। Frame আসছে না? হ্যালো আসসালামু আলাইকুম চেক ওয়ান টু থ্রি ফোর ওয়ান টু থ্রি ফোর ওয়ান 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 ভাই না ওখানে সোর্স এখানে ডিসপ্লে অলওয়েজ ডিসপ্লে যে এই যে আমি অন করে আছি উনি গেলেই হবে ঠিক আছে উনি জাস্ট এখন যদি জয়েন করেন আমরা চেক করে নিতে পারবো আপনি একটু ফোন দিয়ে একটু বলে দেন যে ওই একটা ব্ল্যাক স্টিকার সিএমএস যে ও হলে ভালো কারণ তো ডিভাইস অনেকের তো কারণ আমরা তো অন্য সময় নিজেদের সম্পূর্ণ সেটআপে কাজ করি বাট এখানে তো কয়েক- কয়েকটা যখন থাকে তখন আসলে সেদিন আমার ওই ব্ল্যাক ম্যাজিকের পাওয়ার কেবল মাথা আমার নষ্ট হয়ে গেছে আমি খুঁজে পাই না কে কখন আজকে আসলে আজকে টাফ বাট আচ্ছা 27 না ওনার নাম কি জাকির হোসেন আচ্ছা
হ্যালো।
হ্যালো সালামালাইকুম স্যার আপনি শুনতে পাচ্ছেন
আচ্ছা,
এটা আউটটা দাও আউটটা আউট
আচ্ছা,
আউট
আমি
স্যার
কি
একটু
স্লাইডগুলো
সময়
একটু
দিবেন
শেয়ারিং করতে
একটু
পারি?
সময়
আমি
দিবেন
দেখতে পারি ঠিক আছে কিনা শেয়ারিংটা। হুম।
একটা সেকেন্ড তুই একটু দেখো তো ইউএসবি সাউন্ডটা জি স্যার আপনি একটু কথা বলবেন আমরা একটু অডিওটা একটু চেক
হ্যাঁ,
করে নিতাম
আচ্ছা, আমি বলছি সিঙ্গাপুর থেকে। শুনতে পাচ্ছেন?
শোনা যাচ্ছে বাট কম সাউন্ড এখানে
হ্যালো, শোনা যাচ্ছে?
তুমি এখানে আচ্ছা আমরা স্যার শুনতে পাচ্ছি আপনি চাইলে স্যার এখন আপনার স্লাইডটা শেয়ার করতে পারেন আমরা ওটা দেখিয়ে
আচ্ছা,
দিব
ঠিক আছে।
আমি
আমি
একটু
আচ্ছা,
জাস্ট
কিন্তু
আপনাকে
আমাকে
একটু
ডিসেবল করা আছে, হ্যাঁ? হোস্ট ডিসেবল পার্টিসিপেন্ট স্ক্রিন শেয়ারিং। তো
স্যার
এটা একটু
আমি আমি
আমাকে
আমি স্যার ওইটা আমি করে
না
দিচ্ছি
করি। আচ্ছা, ঠিক আছে।
স্যার আপনি এখন চাইলেই চেক করতে পারবেন স্যার জি জি
দেখতে পাচ্ছেন?
জি দেখতে পাচ্ছি স্যার স্ক্রিন ইজ ক্লিয়ার স্যার আপনি ফুল স্ক্রিনে গিয়ে এখন চাইলেই পরের স্লাইডে চলে যেতে পারেন আমরা দেখছি স্যার আপনি
ফুল স্ক্রিনে আসছে?
জি আমরা দেখতে পাচ্ছি
নেক্সট স্লাইড আছে?
জি জি এভরিথিং ইজ ফাইন
আচ্ছা,
হ্যাঁ
ঠিক আছে, ঠিক আছে। থ্যাংক ইউ। হুম।
জি
তাহলে
স্যার
আমরা আমি এইভাবেই রেখে দিব একটু স্ক্রিন এটা ইয়ে করে শেয়ারিংটা স্টপ করে আমি এইভাবে রেখে দিচ্ছি, হ্যাঁ? আমি
জি
কানেক্টেড থাকছি, ঠিক আছে?
ঠিক আছে ঠিক আছে
আচ্ছা, আমি কি অন্যদের প্রেজেন্টেশন গুলো ইয়ে করতে পারবো কিনা, ফলো করতে পারবো কিনা?
অন্যান্য বাকি যারা প্রেজেন্টেশন দিবেন
হুম, হুম,
হ্যাঁ
তাদের
হ্যাঁ জি
প্রেজেন্টেশন।
জি আপনি দেখতে পারবেন স্যার আপনি জাস্ট এখানে স্ক্রিন শেয়ারটা আমরা বন্ধ করে দিলে পুরো প্রোগ্রামটি আমরা এখান থেকে লাইভ করব স্যার
আচ্ছা, ঠিক আছে। আচ্ছা,
জি থ্যাংক ইউ স্যার আসসালামু আলাইকুম
ওয়ালাইকুম আসসালাম।
এটা হতে পারে যে ওনার ওখান থেকে উনি প্রেজেন্টেশন দিচ্ছেন এটা হওয়ার কোনো সুযোগ নাই তারপর চেক করতেছি ভাই
ওকে ওকে বিষয়টা ওকে থ্যাংক ইউ ঠিক আছে
হ্যালো, আহমদ ভাই শুনতে পাচ্ছেন? হ্যালো,
বিক্রম ভাই,
হ্যাঁ শুনতে পাচ্ছেন?
হ্যাঁ, শুনতে পাচ্ছি।
আচ্ছা ঠিক আছে।
দাঁড়ান বিক্রম ভাই, আর একটু একটু কথা বলি
হ্যাঁ
আমরা।
হ্যাঁ হ্যাঁ
আজকে
হ্যাঁ
সকালে
বলেন।
ঘুম থেকে উঠছেন কখন? অডিও এখানে দেখো তো, ইয়েতে যাও একটু, ইয়ে সোর্সে যাও,
সকালে
ভেতরের
ঘুম
সেটিংয়ে যাও।
থেকে উঠছি হচ্ছে 7টার সময়।
7টায়? আচ্ছা, দাঁড়ান ভাই,
হ্যাঁ,
আমরা একটু অডিওটা দেখছি, একটু ঝামেলা হচ্ছে।
আপনি যে ইয়েতে ব্যাকড্রপে আমার ইয়েটা দেন না, যে ইমেজটা আপনাকে হোয়াটসঅ্যাপে দিয়েছিলাম ওটা ইউজ করেন।
ওকে বস, ওটা দিয়ে দিই, দাঁড়ান এক
ভালো
সেকেন্ড।
হোয়াটসঅ্যাপে দিচ্ছি, ওটা আমি একটা স্কোয়ার শেপ করতে বলছি, ডিজাইন করে দিচ্ছি। স্কোয়ার শেপে দিলে
জি,
তাহলে ব্যাকড্রপে আসবে ভালো মতো হয়তো বা।
জি, এই যে ভাই আমি এখনই ফরওয়ার্ড করে দিয়েছি, আপনি থাকেন, আমরা একটু কথা বলি, হ্যাঁ? আমরা একটু কথা বলি, এক
হ্যাঁ
সেকেন্ড।
বলেন।
হুম হুম হুম। আচ্ছা, আপনি কেন নয়েজটা আসবে? একটা নয়েজ আসতেছে, বুঝছেন, যেটা আসার কথা না।
নয়েজ কি, আমি যে বাইরে এই কারণে আসতেছি কিনা?
না 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 না, এখান থেকে এই প্রবলেমটা সম্পূর্ণ এখান থেকে হচ্ছে। দাঁড়ান এক সেকেন্ড। আপনি আহ, এখন
হ্যাঁ
কথা বলেন তো আবার।
হ্যাঁ শুনতেছেন? হ্যালো,
জি, শুনতে পাচ্ছি
আমি এই যে
ভাই।
করিডোরে বাইরের দিকে যাচ্ছি।
আচ্ছা, ওকে, ঠিক আছে, ঠিক আছে, ওকে ভাই, ওকে। আপনি
ঠিক আছে।
চলে আসুন, জি, থ্যাংক ইউ।
আচ্ছা, ওকে ঠিক আছে।
সমস্যা হয়েছে সিগন্যাল টিগন্যাল সব ঠিক আছে মাইক্রোফোন কাট এসে গেছে সিগন্যাল টিগন্যাল সব ঠিক আছে কিন্তু আপনার ভয়েস লেভেল নাই ওই কাট এসটা দেখেন চেক করে হ্যালো গৌতম দা দেখেন হ্যালো চেক হ্যালো হ্যালো চেক
আউটে মানে আমি বুঝলাম না খালি জুমের আউটে নয়েজ কিন্তু মিউজিক চাইলে তো পাচ্ছে না মিউজিক চাইলে পাচ্ছে জুম তো আর নয়েজ প্রডিউস করে না আমি আবারও মিউজিক চাইলি বা
মিউজিকে সেটা তো তুমি স্টপ করে দাও মানে সাউন্ডটা দিতে
সাউন্ড ঠিক আছে জুমের সাউন্ডটা তো
তুমি সাউন্ড আর মিউজিক সাউন্ড আউট একটা
একটা ঠিক আছে এখন
স্টপ হ্যাঁ গ্রুপ থেকে ওইটা মানে পুরো প্যানেল থেকে নষ্ট আছে
এখন নয় আছে
হ্যাঁ
হ্যালো শুনতে পাচ্ছেন আপনি নিশ্চয়ই নয়েজ আছে জুমে নয়েজ আছে হ্যালো, নয়েজ পাচ্ছি না। আপনি তারপরে যদি মানে ওইটাতে অ্যাম্বিয়েন্ট একটা নয়েজ আছেই, বাট আমি কোনো নয়েজ, হ্যাঁ, পাচ্ছি না। হ্যাঁ, দেওয়া যাবে। নয়েজ আছে, এই নয়েজে কোনো সমস্যার কথা না। আমার জাস্ট ইন আউটে জাস্ট প্রবলেম। আমি যে আউটটা দিচ্ছি,
আচ্ছা আমাদের ওই যে ল্যাপটপ কেবল দিয়ে ডাইরেক্ট আউট। Check. Hello.
check. Check. Hello, hello. Check. Hello, 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 hello. দাও আছে ওটা। Check.
আপনি ভাই আপনি কি পিসিআর রাষ্ট্রীয় পিসিআর ইউএসবি থেকে সাউন্ড সোর্স নাই বুঝো ইউএসবি সাউন্ড সোর্স একটু চেক করো না
হ্যালো, আমি আমারটা থেকে কি করছি মানে
বাইরে তো আপনার এখানে আবার আপনার মাইকে ও আবার রিপিট করছে হ্যাঁ আচ্ছা ওই যে ইকরাম ভাইরে আবার বলবো হ্যাঁ হ্যাঁ পার্টিসিপেন্টসে আছেন আমি আপনাকে কোনটা পিসিআর না এটা 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 করা ভাই এটা ওয়েবিনার না এটা মিটিং মিটিং ভার্সন সো আপনাকে করা যাচ্ছে না আপনাকে করলে আমাকে যেটা করতে হবে এটা হোস্ট করতে হবে না না কো-হোস্ট করে দেন আমি কো-হোস্টেরও সুযোগ দেখতেছি না এই জায়গায় মানে ওনারা যে অ্যাকাউন্টটা আমাকে শেয়ার করেছে ওটা মেবি শুধু একটা হোস্ট কোনো কো-হোস্টের সিস্টেম নাই এই যে মেক হোস্ট আমি আপনাকে পিন করার অ্যালাউ দিয়ে দিতে পারবো আপনি সেক্ষেত্রে যখন পিন করতে পারবেন আপনার ওই জায়গায় যে কারিগরে কিন্তু মাথায় রাখেন আপনার ওখানে পিনের কারণে কিন্তু আমার এখানেও ফাংশনিং হবে আর কি ঠিক আছে টোটিসের রাষ্ট্রীয় নয় এখন এখন তো বাইরে কেউ কথা বলে আমরা এখন প্রবলেম সলভ হয়ে যাবে এখন অডিওটা চেক করে ফেলি তোমার আছে জুম
দেখতেছি।
ইকরাম ভাই কি আছেন ভেতরে আরেকবার ভাই চেক করব ভাই ঘুম পাচ্ছে প্রোগ্রাম দেখো 8:30টায় শুরু কয়টা হবে
আমাদের 10টায় দিছে তো।
আমরাই মনে হয় গেস্ট আমি চলে যাব জাস্ট একটু কান হলে আমার একটা ছোট মিটিং আছে
আমাদেরকে অফিস টাইম বলছে 10টা, আমাদের অফিস টাইম
আমাদের
10টায়
বলছেন
স্টার্ট।
8-9টায় মানে সবাইকে 1 ঘন্টা করে আগে রাখছে
আর বাংলাদেশ
ব্যানারে লেখা 8:30টায়
বাংলাদেশ টাইম তো জানেনই।
আপনি আমি তো বাংলাদেশ টাইম মেনটেন করলে বিপদ প্রোগ্রাম 10টায় আপনি আমি যদি 11টা এসে ঢুকি বাংলাদেশ টাইম মেনটেন করে তাইলে তো মনে করেন সব শেষ হ্যাঁ কিন্তু রাতে প্রোগ্রাম শেষ করে ঢুকবে
আমাদের তো সেটআপ কমে গেছে, রাত্রেবেলায় কমছে, মানে আমাদের ফুল সেটআপ আসার কথা।
আমি আপনার কথা যা সেই কবে প্রোগ্রাম করলাম কবে সার্ভের না না সার্ভের প্রোগ্রামে আমি যে শুনলাম যে মামুন ভাইয়ের যে শুনলাম একটা মাউন্ট আছে না যে সজীব হলো দলছুটের এখন জিজ্ঞেস করতেছিলাম তখন বলছিল আমি তো জানি আপনি এখানে নাই আমি শুনলাম লোকটা আছে কই মানে কোথাও না কোথাও তো সে আছে সে তো আর বলে আছে কি যেন একটা প্রতিষ্ঠান তাই না ওকে আর এখানে কতদিন 3 মাস কেমন লাগতেছে ভালোই ও তাহলে এটা ভালো কাজ করছেন হ্যাঁ ওরে ব্যাকড্রপ না এটা খুব ভালো কাজ করছেন আস্তে আস্তে শুরু করা দরকার তুমি ব্যাকড্রপে এটা একটু দিয়ে রাখো আমি ফরওয়ার্ড করে দিতেছি এটা জাস্ট ব্যাকড্রপে দিয়ে রাখো
হ্যালো, শোনা যাচ্ছে?
অনেক বেটার
হ্যালো।
হ্যাঁ জি এটা দিয়ে কর্ডলেসটা দিয়ে ও দেয়া আছে হ্যাঁ জি ভাই আমি শুনতে পাচ্ছি আপনি শুনছেন
আচ্ছা আচ্ছা, হ্যাঁ আমি শুনতে পাচ্ছি, সাউন্ড ক্লিয়ার এখান থেকে, মানে আপনার ওখান থেকে সুন্দরভাবেই আসতেছে। আমার এখান থেকে কি ক্লিয়ার শোনা যাচ্ছে?
জি জি স্পষ্ট আছে
আচ্ছা, যাক তাহলে ভালোই। টেস্টিং করতে হবে।
জি
আরো চালিয়ে যাবো কথা?
না না, ফাইন, ঠিক আছে, ঠিক আছে।
ওকে, ঠিক আছে। ওকে,
ওকে জি, থ্যাংক ইউ।
ওয়েলকাম।
চেক বন্ধ করা আছে না চেক হ্যালো 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 একটা জিনিস দেখবো আমি সেটা হচ্ছে আমরা তো 3-এ চলে গেছি তাই না 4-এ চেক 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 হ্যালো হ্যালো আমরা 4-এ আছি তাই না 3-এ আছে হলো 3-এ 2-এ আছে ও ঠিক আছে চেক হ্যালো চেক হ্যালো হ্যালো লেভেল শো করতেছে না চেক হ্যালো ওকে ঠিক আছে
আছে? অন করে দিন না।
স্লাইড শোটা করে দিন। হ্যাঁ
ম্যাডাম কোনটা? এটা এটা এটাই তো।
ইয়েতে দেবেন পুরোটা। দেখি একটু স্লাইড শোতে। আচ্ছা পাশে এটা না রাখলেই ভালো, মানে আমি বলবো এটা দিয়ে,
আচ্ছা
কারণ এটা দিয়ে বলতে গেলে না ছোট বেশি হয়ে যায়, চোখে পড়ে না।
আচ্ছা উনি ম্যাডাম চাচ্ছেন পাশে এটা না আসুক, নেক্সট স্লাইডের ইয়েটা অপশনটা না আসুক। হ্যাঁ
হ্যাঁ পাশেরটা প্রয়োজন নয়, আমি এটা দিয়েই চলে যাব।
স্ক্রিনে পুরোটাই আসবে ম্যাডাম,
না স্ক্রিনে পুরোটা আসলে আমার বলার জন্যে
দেখতে অসুবিধা হয়।
হ্যাঁ
আচ্ছা আচ্ছা, এটার একটা সুবিধাও আছে, নেক্সট স্লাইড কি একটু চোখে চোখে আসে আর কি।
অবশ্য দেখি বেশি ছোট হয়ে গেলে একটু প্রবলেম। আমার আবার একটু শরীর খারাপ তো, মানে
আচ্ছা আচ্ছা,
ঝামেলা লাগতেছে। একটু বড় থাকলে এখানে আমার জন্য
সুবিধা হয়।
সুবিধা হয়। এটা বাদ দিয়ে এটা করা যাবে না?
এটা
স্লাইড
আমি
শোটা
দেখি
দিয়ে
ওরা,
রাখলে মানে
এটা স্লাইড শো দেওয়া আছে এখন।
স্লাইড শো আসলে তাহলে এটা কেন? আমি একটু পরে স্লাইডটা চাচ্ছি না, হ্যাঁ আমি জাস্ট পুরোটা স্লাইড শো চাচ্ছি। তাহলে হয় কি আমার এমনি শরীর খারাপ তো, মানে
দেখতে
আমার
সুবিধা হবে।
দেখতে একটু সুবিধা হয়। এটা থাকলে এটা ছোট হয়ে যায় তো, কারণ এই লেখাগুলো একদম ছোট হয়ে যাচ্ছে তখন। হ্যাঁ এটা আমার বড় হলে সুবিধা। প্রথমে চলে যেতে হবে তো।
এটা হচ্ছে সায়েন্টিফিক সেশনে সেকেন্ড পিকচার।
সেকেন্ডটা হ্যাঁ আমি সেকেন্ড হিসেবে দিয়ে রাখি।
আপনার পেন ড্রাইভ আমরা দিয়ে দিতে পারি এখন।
হ্যাঁ সেভ
কপি
করে
দিচ্ছি।
রেখে, কপি করে রেখে আমাকে দিয়ে দেন।
আর এটা দেখি ওনারা পারেন কিনা।
হ্যাঁ একটু করে দিলে ভালো হতো, কারণ আমি আসলে আমার
Good morning, dear audience. All the audiences are requested to be seated. We are going to start our scientific session 1 very soon. Dear audience, good morning. All are requested to be seated. Good morning to you all. Due to some unavoidable circumstances, we are going to start our scientific session 1. Scientific session 1 will be moderated by Dr. Faiz Ahmed Khondokar, Associate Professor, Department of Hepatology, Shohid Sohrawardi Medical College Hospital. I am requesting Dr.
Which is going to be organized by the Bangladesh Stem Cell and Regenerative Society. So, as you have already heard that the first scientific session 1 is going to be started, which will be followed by the inauguration ceremony. I am Dr. Faiz Ahmed Khondokar, working in Shohid Sohrawardi Medical College in Department of Hepatology. So, in this scientific session 1, this session is going to be chaired by Professor Asadul Islam, who is the chairman of Department of Transfusion Medicine, BSMMU, and Professor A.K.M. Salek, Chairman, Department of Physical Medicine and Rehabilitation. I would like to request them to come up in the dais. And in this session, we have got 3 speakers. Dr. M.M. Jaman, Associate Professor, Department of Physical Medicine and Rehabilitation, Department in Dhaka Medical College. Professor Jasmine Banu, he is the Chairman, Department of Reproductive Endocrinology and Infertility, Bangabandhu Sheikh Mujib Medical University. And the third speaker, Dr. Mohammad Zakir Hussain, he is the Chief Scientific Officer, Toticell Limited, former Head of Transgenic Research, Cancer Science Institute of Singapore, National University of Singapore. He will be connected. He will join the seminar virtually. So, first of all, I would like to request Professor Jasmine Banu, who is the Chairman, Department of Reproductive Endocrinology and Infertility, Bangabandhu Sheikh Mujib Medical University, to deliver her speech. She will talk on novel approaches for changes in premature ovarian insufficiency with stem cell therapy. And let me talk few more words that each speaker will get 12 minutes to talk on their respective topics. And once all the talks are done, we will ask their questions and our speakers will answer them. Thank you.
Respected Professor, Professor of Emeritus, Dr. A.K. Azad Chaudhary, and former Chairman of University Grant Commission of Bangladesh, and the Chief Guest of Professor Dr. M.D. Sharfuddin Ahmed Sir, sir, and the Chief Guest of this session, and all the audience are the Assalamu Alaikum and good morning to all. Before I going to present my topic, I would like to talk about what is premature ovarian failure. Actually, premature ovarian failure, before we go into premature ovarian failure, the normal ovary produce the number of the follicle and reflecting the egg. But in case of the premature ovarian failure or insufficiency, there is a failure to the producing the ovum. And there are other option is the failed, then stem cell therapy is the new hope for the infertile couple and recurrent IVF failure. The introduction. premature ovarian insufficiency is one of the main cause of the infertility of the childbearing age. The etiology and the pathogenesis of the premature ovarian failure or premature ovarian insufficiency are complex and not very clearly at present. 25 to 30% patients are ovulate spontaneously, and among them 5 to 10% patients of the premature ovarian insufficiency are conceived spontaneously. And the ESHRI recommended that the diagnostic criteria when the patient presented with the oligomenorrhea and amenorrhea before the age of the 40 years, and the biochemical parameter at the FSH level more than 25 milli-international per ml, and the serum E2 level more than 50 picomole per liter, and the transvaginal sonography showing the antral follicular count less than 5 follicle, small ovarian volume, and endometrial thickness less than 4 millimeter. And the incidence of the premature ovarian insufficiency increases according to the age. When the age is less than 30, incidence is 1 in 1,000 reproductive age group. But when the age is the 40, and then incidence of the premature ovarian insufficiency is 1 in 100. And among the primary and the secondary amenorrhea, the more common in the primary amenorrhea is the premature ovarian insufficiency, that is the 10 to 28%. And spontaneous incidence of the premature ovarian insufficiency is 1.1% in the reproductive age group. And spectrum of the POI, that is the first of all we call the occult POI, that is the early stage of the premature ovarian insufficiency. There have the patient presented with the menstrual irregularity or unexplained infertility or repeated IVF failure. But at this time, the FSH level was normal, but and ovary is functioning. And that is the reversible POI. Reversible POI means that premature ovarian insufficiency, that is the chance of the occurrence of the amenorrhea and the climacteric symptom, and FSH level is the high at that situation, and it is the more than 40 milli-international unit per ml. And the causes of the premature ovarian insufficiency, that is the iatrogenic, idiopathic, infectious, autoimmune, environmental, and genetic cause. At that time, the most of the 50% patients are suffering from the POI is due to the idiopathic cause. And the classification of the premature ovarian failure, functional classification, that is it is due to the ovarian depletion or due to the ovarian follicular dysfunction, that is the qualitative deficiency and quantitative deficiency. Qualitative deficiency is the ovarian follicular depletion, that is due to the iatrogenic cause or the idiopathic cause, and that is the qualitative deficiency, that is due to the genetic defect, idiopathic, and autoimmune cause. And the clinically suspected the premature ovarian insufficiency is due to that there is a family history of the premature ovarian insufficiency, and there is some environmental cause, and they presented with the menstrual history, that is the irregular menstruation, and the previous gonotoxic or the chemotherapy or radiotherapy history, and history of the autoimmunity, that is the clinically suspicious of the premature ovarian insufficiency. And the lab parameter, they're showing the AMH level less than 1 nanogram per ml, FSH level is the more than 25, and the antral follicular count is less than 5. And the TVS, when the TVS, transvaginal sonography shows the normal ovarian volume and antral follicular count more than 6, that is the premature ovarian insufficiency is unlikely. And in patient with the occult POI, that is the FSH level is normal, but there is a sign symptom of the premature ovarian insufficiency, and this patient are spontaneous pregnancy with the IVF program and its own oocyte. And the management dilemma, after the diagnosis, the management dilemma is there is no better treatment for the premature ovarian insufficiency because repeated gonadotropin stimulation. So the last and the most promising is the egg donation. And egg donation is not an acceptable in our perspective due to the religious, cultural, or ethical issue, and because donated egg can never have their biological offspring. So new therapy for the premature ovarian insufficiency, autologous stem cell therapy for the ovarian rejuvenation is a promising treatment. And now what is the stem cell therapy? Stem cell therapy is attracting attention in the field of the regenerative medicine and is advancing rapidly to treat the reproductive system disease. And the stem cell therapy is an attractive, non-invasive treatment and aims to replace the damaged cell within the body. And then unique in that they have the ability to self-renewal and differentiate it into a specific tissue according to the surrounding environment and the signals. And the history of the stem cell therapy that is performed by the French oncologist and the 1958 who had been first introduced the stem cell therapy in a accidentally patient and a critical ill patient. And thereafter, the 1968, Robert A. Gott performed the first successful bone marrow transplantation. And 2006, the adult stem cell therapy is the first introduced. And 2010, there is a first treatment of the spinal injury with the stem cell therapy. Type of the stem cell, that is the, according to the differentiation, that is the totipotent, pluripotent, multipotent, unipotent, and pancreatic. And the embryonic stem cells are not frequently manipulated in research because the ethical region and it is the cancer risk. Stem cell therapy is divided into the, according to the differences, the pluripotent and the multipotent stem cell. And the embryonic stem cell are the most are the pluripotent stem cell, and they derived from the inner cell mass of the blastocyst and differentiate into various cell type. And embryonic stem cell are differentiated in the derived from the ectoderm, endoderm, and from the mesoderm. And the mesenchymal stem cell are derived from the umbilical cord tissue, allowing the cell to be transplanted in the wide range of the people without fear of the rejection. And the mesenchymal stem cell are derived from the adipose tissue, amniotic fluid, dental tissue, endometrium, menstrual blood, peripheral blood, and the placental and fetal membrane. And the mesenchymal stem cell are most of the multipotent stem cell, and it has got the property of the low immunogenicity and limited immunomodularity function and undergo the chemotaxis in the wound healing. And it has the ability to the self-renewal potential is limited by the donor age. And it is the invasive procedure and including the bone marrow aspiration and the liposuction. And it is the mesenchymal stem cell, it derived from the bone marrow, adipose tissue, endometrium, umbilical cord. And when it decreases the oxidative stress and increases the angiogenesis and myelination. And there are several studies, the myomedicine and the pharmacotherapy, and the 2018 June, the current approach for the treatment of the premature ovarian failure with the stem cell therapy. They showed that the stem cell therapy have the self-renewal and the regeneration potential, hence they can very effective in the treatment of the ovarian failure and consequently infertility. And autologous transplant, there is the autologous transplant and the source of the growth factors, cytokine, stem cell, and can be used for the ovarian regeneration and the oocyte regeneration. Autologous stem cells are exclusively on the peripheral blood stem cell rather than the bone marrow. Why it is the important, that is the, is it easier to collection, that is the peripheral blood stem cell, and more homeopathic recovery and decrease cost. And another journal, research of the ovarian research, and 2020, June 2020, the recent change in the stem cell therapy of the premature ovarian insufficiency and its therapeutic potential review, and showed that the its positive effect in enhancing and restoring the ovarian function, such as the improve the folliculogenesis and decreases the gonadotropin apoptosis, increases the vascular formation and genetic stability. Since the stem cell are a proven new therapeutic strategy for the future cure of the ovarian dysfunction. And another study, there is the role of autologous bone marrow-derived stem cell therapy, follicular recruitment in premature ovarian insufficiency, review a literature, a case report, world first baby with ovarian autologous stem cell therapy in premature woman of the age 45 years. After the 8 weeks of the bone marrow stem cell therapy introduced, ultrasound revealed the 2 follicles in the each ovary and additional AMH level is improved. So considering the age of the patient, the first cycle of the egg pooling was planned immediately, and the Indian first baby with the novel therapy, but also maybe the world first baby with the bone marrow transplantation therapy at the 45 years of age, because before that the first baby was born, the age is below the 40 years. And another study, the international genetic patient, it's the critical shortening of the telomere, and their telomere death is prevented, and so the telomerase activation allow the overcome of the apoptosis and increase the cell longevity. And another National Library of the Medicine showed the first baby autologous stem cell therapy in the premature ovarian failure in February 26, 2015. And now the research work in our BSMMO, total 5 patients, subfertility with the premature ovarian insufficiency are selected for the stem cell therapy in 2 batches. Among them, 1 patient was the PIA. And second batch is also 2 patients are the premature ovarian insufficiency. And lab parameter of all patients in favor of the premature ovarian insufficiency and the planning for the stem cell therapy. And follow-up was done after 1, 3, and 6 months with the hormone, and the AFC count will be done. And the most of the patients have all the therapeutic effect of the treatment last for the 5 to 7 months. And the first patient was the FSS level was the 22.2, and the post-stem cell therapy, FSS is reduced in the normal condition in the 6.8. EMH level is not so much improved. And the AFC count was 2 to 3 follicle, but after the stem cell therapy, it was in the 4 to 5 follicle in the right ovary and 6 to 7 full in the left ovary. It is dramatically improved. So this patient is no need of the IVF further, and we are planning for the IUI in the next cycle. And another 2 patients are waiting for the administration and follow-up in the next cycle. And in the second batch, and the first time in the December was introduced the stem cell therapy, and they will come the follow-up in the January. And it is the stem cell therapy is transplantation into the ovary. And first picture, that is the ovarian. First picture, that is the premature ovarian insufficiency, that is a small ovary. And second, that is the after transplantation of the stem cell into the ovary through the laparoscopy. And it is the collection of the stem cell and remodeling of the stem cell. And the third picture is the introduced in the stem cell through the laparoscope in our BSMMO setup. Conclusion, the POI is the one of the common disorder found in the 1% of the female infertility, and the premature ovarian failure are the hypoestrogenic or estrogen deficiency, increased gonadotropin level, and amenorrhea. The gold standard diagnostic is a change in the level of the main ovarian hormone. Currently, the prevention and treatment of the premature ovarian insufficiency are extremely limited. And stem cell therapy has shown a great potential for the reversal of the premature ovarian failure or premature ovarian insufficiency in treating the infertility. New therapeutic strategy, stem cell therapy contains such as the messenger RNA for the future cure of the ovarian dysfunction, such as the folliculogenesis and the granulocyte cell, apoptosis rate, and the vascular formation and the genetic stability. Limitation, and the following transplantation of the stem cell
efficiency. Now I would like to request Dr. M.M. Jaman, who is the Associate Professor, Department of Physical Medicine and Rehabilitation in Dhaka Medical College, to come up in the dais and present his speech on bone regeneration, hype or hope. Hello. For some technical problem, we are going to the third speaker. That is Dr. Mohammad Zakir Hussain. He is the Chief Scientific Officer, Toticell Limited, former Head of Transgenic Research, Cancer Institute, Cancer Science Institute of Singapore, National University of Singapore. He will be connecting with the seminar through online, and
to present a talk. So here I'd like to start with my presentation, dear distinguished guest and audience. I'd like to give you just some overview of our, some of the development in Toticell. Toticell is a private company. It was actually incorporated in 2019. So I'm just serving as a Chief Scientific Officer. So here I'd like to give you that what we have been doing actually, in fact. So our main objectives is regenerative medicines, in fact. So regenerative medicine, it can be the scope of the regenerative medicine could be invasive transplantation approach, a minimally invasive biological approach, as well as non-invasive non-biological approach. So that's one of the issues. What I would like to tell you that we are dealing with the stem cell therapy and also the functional cell therapy, and as well as genetically modified cell therapy. That is our actual overall objectives. And those cell therapies we can actually categorize in the regenerative cell therapy and adaptive cell therapies. This is based on that the stem cells which can be modified to adapt into some therapeutic specific functions. So, and this is the, if I really want to classify this, if I want to give you the overview, let me classify these total cell therapies until today. So even the cell therapy was originated in 19th century. So we are now currently most of the actual cell therapy we are now dealing with the second generation and first generation cell therapies. As we know that stem cells can be also produced by reprogramming techniques, which is called induced pluripotent stem cells. So that is also some hard work is ongoing, and it will be in future as coming into our clinic as a therapy. And on top of it, as you can see at the right side, we have a fourth generation cell therapies, which you can call it CAR-T, CAR-NK, or genetically modified hematopoietic stem cells, as well as genetically modified mesenchymal stem cells. And also another is fourth generation, which can be where we can do the genetic modification, or we can do the gene editing. And this is actually genetically modified. So most of the cases, we started our projects with this in the left side, which is called the first generation and second generation cell therapies. And of course, we are leading to the fourth generation and fifth generations. And that's we are thinking about that, to bring new technologies and to bring new infrastructures to bring in Bangladesh. So, and here you can see that in the second generation, one of the cells we are producing is mesenchymal stem cells. As you know, that just already from the previous speaker that it can be autologous and allogenic. So, and so far allogenic stem cells draw a big interest in the therapeutic purposes. So I can tell you that what I did, we are doing in this stem cells preparations or stem cell production, So usually, again, I don't like to focus these things actually. As you know that this can be stem cells, mesenchymal stem cells can be isolated from different types of tissues, including bone marrow, adipose tissues, umbilical cord, dermis, and synovial membrane, and also dental pulp. However, most of the cases, allogeneic stem cells are isolated from umbilical cord. And there are some criteria which has been published by International Society for Cell and Gene Therapies, that this mesenchymal stem cells should show plastic adherence, and also they should express some of the cell surface marker like CD105, as well as CD90 and CD73, and there should be some negative cell surface marker as well. And those cells could also be differentiated into osteocytes, chondrocytes, and adipocytes to prove that, I mean, that tells that these are really stem cells, in fact. So, and so for several stem cell therapy has been already under, several company is now marketing their stem cells, especially for some diseases called chronic disease, bone adipose tissue degeneration, graft-versus-host disease, and also acute myocardial infarctions. So this has been given approval to be used as a treatment for different types of disease that I mentioned. As you can see that in our protocol, when we do the MSC productions, as you can see that it starts with the umbilical cord collection first. And this umbilical cord connection is actually done based on some questionnaires which can exclude maternal, paternal disease history of maternal, paternal siblings, as well as genetics to autoimmune diseases, travel history of to lifestyle, also some uncommon treatments that has been excluded by questionnaires. And also some of the immediate infection has been actually tested molecularly from the, especially from the mother, using mother blood. So we make sure that that mother is not having some infection in her lifetime, actually. So we exclude those kind of infection parameters. So on the basis of that, you see, we started with the piezo culture when umbilical cord. We usually there's two way we can start culture, is called explant culture, also enzymatic digestion method as well. So we prefer explant culture because it's produced better, good quality MSCs. And these MSCs you can pass through, usually when the stemness is there, it passes through until 20 generations or something. But in our facility, we plan to passes until passes 5 to keep this chromosomal integrity and to maintain the better stemness or something. And different stages, we apply different types of quality testing, including sterility testing. We also confirm trilinase differentiation immunophenotyping in passes 3, as well as we also finally, when therapeutic stock, we will be doing again one more sterility testing, microbiome testing, as well as endotoxin assays to confirm that our cells is actually clinically competent. And as if you look at this explant culture, how we do, actually once we get the cord tissues from mother based on our screening criteria. So we do, for explant culture, we dissect the tissues, we remove those, all the blood vessels. And after removing the blood vessels, we chop these tissues into the 2 to 3 millimeter pieces, and we set the explant culture. And using that cell culture incubator, and this is a very traditional media for MSC culture. We're using FBS system. We start culturing, and you see that there is the outgrowth. You can see from this small explant starting by day 6. It can start it from day 6 to by day 6 or by 12 or something. So we in our facility, when we can see that there's that outgrowth is even, we can see even at the early stage by 6 days. And this is the further expansion we do. And after that, we also test by, do the sterility testing. After further, when we are reaching to the different stages of passes, we actually conduct sterility testing for aerobic and anaerobic bacteria. We also test the mycoplasma because we are using a genogenic system using FBS, fetal bovine serum. And also we test the endotoxin levels. So as you see that our production facilities are producing very acceptable range of quality of MSC. So, and we really go back to what is the therapeutic effect of MSCs. As you can see that MSCs, they can actually, they have a lot of cell surface receptors, and they can sense the environment. And they can detect, based on that, they can actually sense the inflammation, they can sense the also the injuries as well. And this, they can secrete cytokines, chemokines, growth factor, niche factors, and also different exosomes. And those can actually mediate immunomodulation and also do regeneration, as well as also they, those can help them to also maintain the stemness for them, as well as also when we are injecting, when we are, these cells are going to the certain injured tissue over there, they also help them to activate their stemness as well. So this is the all done by this chemical factor secreted by this stem cells, mesenchymal stem cells. And as an example here, I can tell you that how the regeneration process goes in and why the immunomodulations and regeneration is very important. As you can see that as an example, I can tell you there is a skin regenerations. Usually when skin is injured, there's a response by inflammation, there's this inflammation is there. And then after inflammation, the proliferation begins, and then wound start to contract and remodel. And finally, we can see very fine healing. But when this inflammation and proliferation is not defined, is not proper balanced, then actually we can develop a certain type of, hypertrophic and caloridosis as well. So this kind of things is that is not actually our desired regenerations. We expect this kind of regeneration. So in this case, actually what I want to say that when there's injury, there's inflammation, and anti-inflammation has to be balanced, which is actually called as the immunomodulation. And at the same time, those after that inflammatory response mediated by balance, then it should be, there should be some regeneration coming from using growth factors. And as you see that I can tell that MSC has all of this package of molecules that which can actually induce angiogenesis and prevent scarring and accelerate healing. So this is a very excellent therapeutic modalities for regenerative medicine. And if you look at the 10 top specialties, clinical trials, you can see that almost 10 top specialties is holding 90% of the clinical trial. Those are the traumatology, pneumology, neurology, cardiology, immunology, hepatology, endocrinology, dermatology, gastroenterology, or also nephrology, and also there's some other indications as well. So you see that the most of this is the all are containing a vitals or vitals organs, and most of the vital organ related disease, especially degenerative or chronic diseases, as this can be targeted with the mesenchymal stem cells. And in our facility, we have also planned to conduct this, our clinical trials, but again, we plan to recruit once we still are not having a complete set of mesenchymal stem cells for our clinical trial, but we are aiming to develop our therapeutic ampoules, and we are planning to recruit some patients as well as also to check the safety, preventing further complications. This is the endpoint objectives, and improve quality of life with little to no complication, as well as extension of lifespans in kind of some very devastating disease, including IHDs, CLD, CLF is a liver disease, acute on chronic liver failure, also ILD and CKD, and Alzheimer's and Parkinson's disease. So that will be our target patients to design some of the clinical trials using our MSC produced in our facilities. But again, what I have to say that clinical trial is more challenging, not in terms of that, cell biology, not in terms of the patient screening. Actually, the most challenging is that how to target the patients or the tissues actually. So this delivery route is a very challenging step. So we would like to all the expert doctors and clinicians in Bangladesh actually who will have a better experience and collaboration in intracoronary artery manipulation, also sinus as well as hepatic artery is one of the great way to treat the liver diseases as well. Intravenous is very common, but also intertracheal is another great way to treat liver diseases, so lung diseases, and also interrenal parenchymal resources, including GMP laboratory, car banking. clinic. You can see our GMP facility and also our cryobanking. And we also, there's EW Villa Medica. We have in collaboration with them also. We are putting rehabilitation approach together with the cell therapies. This is in our plan. And also the molecular diagnostic facility, DMFR molecular diagnostics. So that we are working together with them to develop our clinical protocol. So as you can see that our facility have both autologous and allogeneic cell therapies. Not only MSC is coming from umbilical cord. Besides, we also can process peripheral blood, adipose tissue, and bone marrow. We can give PRP, SBF, and BMC. And if you look at that, our PRP therapy is producing a very high dose therapy, as well as a very high pure therapies. Is one of the analysis we give you that we can produce, this is one of the PRP therapy, we call it RGX therapy. So this gives 7.8 billion of platelet and also 91% purity of the platelet, which is, we call it as a very high potency PRP therapy. And those therapies we are using in for already started in treating the patients. Besides, we also have a plan to have a SBF therapy, stromal vascular fractions from adipose tissues, and also bone marrow concentrate from the bone marrow. And because those cells actually is heterogeneous cells, as I said, it's the first generation cells. But very good things about that, they have stem cells, progenitor cells, also matured cells. And in the meantime, they also do immunomodulation and regeneration. So they are the excellent cell therapeutic approach for different regenerative disease. And if you can look at that using this PRP, MSC, SBF, and BMC, we plan to treat many diseases, including orthopedic conditions, autoimmune diseases, metabolic conditions, neurology, aesthetic indication, eye conditions, or muscular indication, and as well as muscular atrophies. And we already giving the PRP therapy or RGX therapy in frozen shoulder, osteoarthritis, hair fall, non-healing ulcers, also in erectile dysfunction. And we are getting very tremendous results actually in the patient feedback, but unfortunately I have no time to share this data. In future, we plan to share this outcome. So again, we have a future plan that was as another therapy. It's called autologous chondrocyte transplantation techniques. So this is we call is a functional cell therapy, because why is functional? Because we are giving the functional cells. Because when there's osteoarthritis, one common problem. So where the cartilage is affected severely, then actually, so they cause a number one MSD conditions and in the worldwide. So we can take the biopsy from the normal cartilage, and we can culture this chondrocyte, and finally this chondrocyte can be implanted together with some kind of scaffold. Of course, this is the first generation autologous chondrocyte transplantation techniques, which is also very still graft, but actually the third generation, we can use some kind of synthetic matrix, a biocompatible or biodegradable matrix. So this can be used to treat cartilage damage in osteoarthritis as well as the defects of patella. And we also have a plan to do allogeneic pancreatic islet transplantations. As you know, that diabetes, type 1 diabetes, they cannot produce insulin. So, and so they need to actually replace with the insulin producing cells, and B cells. Beta islet cells is one of the, this is the only source of insulin. So, and what we can do, we can actually two ways. We can get this beta islet cells from the donor dead body, or we can get the beta islet cells from the reprogrammed cells from the autologous source. So we can make this iPS cells from the patients and can revert back these iPS cells into beta islet cells. And those cells can be transplanted into the probably people heard about that. Is called CAR-T and CAR-NK, and also genetically modified MSCs. And those cells has been used to treat aggressive cancers. So even metastatic cancers as well. So there's a lot of preclinical studies is ongoing, and also using CAR-T has been approved by FDA. CAR-NK is also coming through. In the meantime, another great way to, I just mentioned the great way to engineer the tissue is iPSA, is induced pluripotent stem cells. It means the adult cells can be reprogrammed into the pluripotent stem cells, and then pluripotent stem cells can be converted, differentiated into any cell types. And those cell types, together with this whole type, also hematopoietic stem cells, that is also can be used to treat like beta thalassemia by gene therapy, getting this autologous hematopoietic stem cells and correct the giving the transgenic expression of that hemoglobin protease genes. In the meantime, we also can correct the genes. We can also do the corrections of the thalassemia in the familial thalassemia in the IVF setting and the zygotic embryo by gene editing technologies. So those technologies is now pretty much available and is now is very workable in the clinic setup as well, and many places in the world also they are doing some preclinical studies and trials. So we plan to bring this technology as well. So so after this regenerative cell therapy, that this will be another adaptive cell therapies. So finally, what I would like to tell you that this is our goal of cell therapies. So we want to change the paradigm. That is that the regenerative cell therapies can treat the defects, tissue defects, injuries, as well as it can alter the biochemistry. It can reduce that regenerative potentials. It can improve the regenerative potentials when in chronic disease, there is we believe that regenerative potential is a decrease because of aging and genetic and epigenetic changes, and those we can actually activate back by the regenerative cell therapy. And those I told you that a lot of therapies are clinical trials are ongoing because those activation of regenerative potential can reduce the persistent inflammations, which eventually give a better life and stop the progression of the disease complication. Also can have the critical illness patients as well as terminal illness patients. In the meantime, adaptive cell therapy will be actually giving more better options because even though there will be regenerative, but that we can actually lead the cells to fight the disease, including I tell you that cancer like beta thalassemia, genetic disease and so on, and as well as so we can also change the genetic setup. As I mentioned, the gene therapies and gene editing can be done, and probably using a new molecule, we can also do the epigenetic changes, which is happening in many cancer cells or in tumors. So those kind of epigenetic changes can be actually conducted by the adaptive cell therapies. Unfortunately, we cannot control the age, but rest of the things, I believe that together with the pharmacological treatment and regenerative cell therapy and cell therapy, we are able to change, adapt a new paradigm of patient cares. So, and with this, our new infrastructure program, our plan. So we are planning to have a cord blood banking. We have to set up in vitro fertilization facilities, which will be accumulated, which will be collectively function together with the CRISPR-Cas9 gene editing in the fertilized eggs or oocytes. And as well as also we have a plan to set up a gene delivery systems, which will be a GMP grade gene delivery system as a viral and non-viral gene delivery systems. So those are the infrastructures we are planning, it will be coming in future and over the years. And I believe that in the meantime, we will be very much strong enough to produce these stem cells from using, we'll be able to isolate good stem cells, we'll be able to have a good cell banking, as well as also we'll be able to reprogram the cells genetically or by other means. So I would like to conclude most of my talk here. So in this way, what I want to tell you that eventually we'll be leading the 5th generation cell therapies. So I'd like to acknowledge my colleagues and international advisors actually. So they are from the State University of Singapore and also from India and also from Melbourne. And as well as I would like to thank our chairman, Mr. Faisal Rahman, because his inspiration and patronization was a great force for our these ventures, I believe. So in the meantime, I would like to thank the audience for your patience and hearing. Thank you so much.
Thank you, Dr. Zakir Hussain, for your nice presentation, joining from Singapore. He talked on the progress of development in mesenchymal and stem cell therapy in Bangladesh. Now our last speaker, I would like to request Dr. M.M. Jaman to come up in the dais and start his talk on bone regeneration, hyper hope. He's the last speaker of this session, and this session will be followed by inaugural session. Take us. Okay, sir. Take us, sir. So now we're going to move to our inaugural session because our honorable guests are already here as time constraint. So I would like to request Dr. Ruxana Begum and Dr. Dulal Chandra Das to start the inaugural session. Thank you.
Honorable guest, respected panelists and learned audience, good morning. It's my great pleasure to welcome you all in inaugural session of 2nd Stemcom 2021 and 5th Annual Conference of Bangladesh Stem Cell and Regenerative Medicine Society. Bangladesh Stem Cell and Regenerative Society is the umbrella organization founded by different specialties of the country who are interested in working for their stem cell and regenerative medicine. Stem cell and regenerative medicine is a new horizon in the treatment sector which are creating new hope for patients throughout the world. Every year, Bangladesh Stem Cell and Regenerative Medicine Society organizes conferences. This is a platform to represent their new research to communicate with decision makers. Our Honorable Prime Minister has already given message regarding these conferences.
This year, at the eve of birth centennial of our father of nation, Bangabandhu Sheikh Mujibur Rahman, and at the very occasion of Golden Jubilee of Victory of Bangladesh, we are enlightened to organize 5th Annual Conference of Bangladesh Stem Cell and Regenerative Medicine Society of Bangladesh. At this very occasion, we are proud to have among us our Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, Dr. Sharfuddin Ahmed, Dr. A.K. Azad Choudhury, former We will start our session with national anthem.
তোমার বাতাস আমার প্রাণে ও মা আমার প্রাণে বাজায় বাঁশি সোনার বাংলা আমি তোমায় ভালোবাসি দেখেছি আমি কি দেখেছি মধুর হাসি সোনার বাংলা আমি তোমায় ভালোবাসি কি শোভা কি ছায়া গো কি স্নেহ কি মায়া গো কি আঁচল বিছায়েছ বটের মূলে নদীর কূলে কূলে মাতর মুখের বাণী আমার কানে লাগে সুধার মতো মরি হায় হায় রে মাতর মুখের বাণী আমার কানে লাগে সুধার মতো মাতর বদর খানি মলিন হলে আমি নয়ন ও মা আমি নয়ন জলে ভাসি সোনার বাংলা আমি তোমায় ভালোবাসি
Thank you, everyone. Now, welcome address by Professor Mamun Al Mahtab, Secretary General, Bangladesh Stem Cell and Regenerative Medicine Society.
Very good morning to you all. আজকে যারা এখানে উপস্থিত হয়েছেন তাদের কাছে আমার এই সংগঠন অ্যাসোসিয়েশনের পক্ষ থেকে অপার কৃতজ্ঞতা, কারণ স্টেম সেল এমন একটি বিষয় যা নিয়ে আমাদের মনে ধোঁয়াশা অনেক বেশি এবং এ সম্বন্ধে আমাদের গ্রে এরিয়া কনফিউশন ইত্যাদিতে অনেক বেশি এবং আমাদের একটা ধারণা আছে যে আসলে কি স্টেম সেল করা সম্ভব কিনা, নিয়ে আসলে ক্লিনিক্যাল অ্যাপ্লিকেশন যাওয়া সম্ভব কিনা। এই বাস্তবতাকে মাথায় রেখে কিন্তু 5 বছর আগে আমরা একটা ইন্টারডিসিপ্লিনারি কমিটি গঠন করেছিলাম এই অ্যাসোসিয়েশনটির, যার নামকরণ করা হয়েছিল বাংলা স্টেম সেল অ্যান্ড রিজেনারেটিভ মেডিসিন সোসাইটি। এবং তারপর থেকে কিন্তু আমরা আমাদের ক্ষুদ্র পরিসরে চেষ্টা করে যাচ্ছি যাতে এই বিষয়ে যে জ্ঞানের প্রসার এবং ক্লিনিক্যাল অ্যাপ্লিকেশন সেটাকে প্রপারলি বাংলাদেশে করা যায়, যাতে এটি বাণিজ্যে পরিণত না হয়, যেটি অনেক দেশেই স্টেম সেলের বিকাশের পথে অন্তরায় হয়ে দাঁড়িয়েছে। আমাদের এ পর্যন্ত এই কাজগুলো আমরা করেছি। প্রতি বছর কিন্তু একটি সম্মেলনের আয়োজন করা হয় এবং এইখানেই আয়োজন করা হয়। গত বছর আমরা কোভিডের কারণে ভার্চুয়ালি আয়োজন করতে বাধ্য হয়েছিলাম। বঙ্গবন্ধুর জন্মশতবার্ষিকী মুজিব বর্ষকে সামনে রেখে আমরা পরপর 2টি স্টেমকন বঙ্গবন্ধুকে উৎসর্গ করেছি। এবার আমরা বঙ্গবন্ধুর 2য় স্টেমকন আয়োজন করছি, যা এই অ্যাসোসিয়েশনের 5ম বার্ষিক স্টেমকন। এছাড়াও বাংলাদেশের ওষুধ প্রশাসন অধিদপ্তর যে স্টেম সেল এবং রিজেনারেটিভ মেডিসিন গাইডলাইনটি প্রণয়ন করেছেন, সেখানে আমাদের সোসাইটির গুরুত্বপূর্ণ অংশগ্রহণ ছিল এবং কমপক্ষে 4 জন সদস্য আমরা সেখানে কাজ করেছিলাম। পৃথিবীর বিভিন্ন দেশের বিজ্ঞান একাডেমির একটি সংগঠন আছে, ইন্টার একাডেমি পার্টনারশিপ বলে। তারা 2 বছর আগে সারা পৃথিবী থেকে নমিনেশন সংগ্রহ করেছিল স্টেম সেলের একটা ইন্টারন্যাশনাল স্টেটমেন্ট প্রণয়নের জন্য এবং বাংলাদেশ একাডেমি অফ সায়েন্সেস আমাদের সোসাইটি থেকে আমাকে মনোনীত করেছিল সেই কোলাবোরেশনে যাওয়ার জন্য। সারা পৃথিবী থেকে নমিনেশনগুলো বাছাই করে যে 12 জন সায়েন্টিস্টকে দায়িত্ব দেওয়া হয়েছিল সেই স্টেটমেন্টটি প্রণয়ন করার জন্য, সেখানে আমাদের অবদান ছিল। আরেকটি গুরুত্বপূর্ণ জিনিস হচ্ছে যে আমরা স্টেম সেলের বাইরেও চেষ্টা করছি যে বাংলাদেশের যে সমস্ত কাটিং এজ রিসার্চ হচ্ছে সেগুলোকে প্রমোট করা। আজকে এই সম্মেলনে যে কিনোট লেকচারটি দিবেন তিনি হচ্ছেন ডক্টর কাকন নাগ। তাকে হয়তো আপনারা এখন অনেকে চেনেন না, কিন্তু তিনি আমাদের যে দেশীয় কোভিড ভ্যাকসিন বঙ্গভ্যাক্স তার উদ্ভাবক এবং বঙ্গভ্যাক্সের আপডেট সম্বন্ধে আজকে এই কনফারেন্সে একটি কিনোট লেকচারও দেওয়া হবে। আমি আর কথা না বাড়াই, আপনাদের সবার প্রতি আবারও অশেষ কৃতজ্ঞতা যে আপনারা এই একটি অপ্রচলিত বিষয়ে আগ্রহ ব্যক্ত করে এখানে এসেছেন। আমাদের উদ্দেশ্যই হচ্ছে একটি ইন্টারডিসিপ্লিনারি এবং শুধু ফিজিশিয়ান কমিউনিটি না, বিশ্ববিদ্যালয়ের শিক্ষক যারা নন মেডিকেল পার্সোনালিটি তাদেরকে সমন্বিত করে দেশে ক্লিনিক্যাল রিসার্চ ইন স্টেম সেল অ্যান্ড রিজেনারেটিভ মেডিসিনকে এগিয়ে নিয়ে যাওয়া এবং সেই প্রেক্ষাপটে আমরা কাজ করে চলেছি। অনেক ধন্যবাদ।
Thank you, sir, for your nice delivery. This is time for inauguration. Inauguration of Bangabandhu 2nd STEMCon 2021. I would like to request Professor Emeritus Dr. A.K. Azad Choudhury, former Chairman, University Grant Commission, Bangladesh, to inaugurate the session.
Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, Dr. Sharfuddin Ahmed, Dr. Mamoon Al-Mahtab, the organizer of the conference. We have got guests on the podium and dear audience. It's a proud privilege to be here to talk on or inaugurate on questioning the existence of human race and its discovery of many things are in the offing to treat those diseases. Whether it is heart disease, or heart failure, or brain disease, or spondylosis, or arthritic diseases, or infertility, and you can't discover the cancer, Alzheimer, all the challenging diseases are being challenged by the stem cell research, and there are breakthroughs all over. I don't have much time, but I can only say the growth of stem cell research is increasing by 36 to 40% every year, and the market is about $7 to $10 billion, but it is expanding very rapidly. You see, these diseases are being cured and treated by medically, other approaches are there. But degenerative processes really covers them efficiently. If you talk about the kidney, it could be really cured, and China has made some breakthrough in the chronic kidney diseases with regenerative tissues. And the cancer, many of the lymphocytic leukemia are treated by a stem cell research. If you talk about the heart failure, cardiomyocytes can treat this condition. That is the stem cell research. Infertility, one of the speakers here has also delivered on the issues that problem of infertility can also be taken care by the stem cell research. Now, stem cell research is in the initial stage. Now it has passed to 3 or 4 stages. Many of the drugs are now available, those are treated. Primary condition of the stem cell research, whether it is toxic or the healthcare issues. Bangabandhu Sheikh Mujib Medical University, the prime leader of medical care and research. I have got the practical experiences here. I'm associated with the parent organization, which we call IPGMR. I started my research career in 78, when I came back after doing the postdoc research. Here, Azad Khan, Mahmoud Hassan, and the peer, Nurul Islam, was there, and we carried out research. And it was some of the researchers who were cited in a high impact factor journal. But this Bangabandhu Medical University has a good beginning in the IPGMR. Now the beginning has expanded so much. It has covered a vast area. I can assure you, I can tell you in presence of the Vice Chancellor, that medical care provided in Bangladesh, either in the research or in the development or in the care, is the best in IPGMR and the Bangabandhu Medical University. And they have not left any area uncovered. Stem cell research is a front-page things, you know. This has been taken and spearheaded by Mamoon Al-Mahtab groups. We're really thankful. And the August gathering of our 50th anniversary of independence and of Bangladesh and liberation war, not independence and also liberation of Bangladesh. And it is 100th birth anniversary of Bangabandhu Sheikh Mujibur Rahman. I gratefully gracefully and so to say obediently declare the conference open. Thank you.
Regenerative medicine is really a topic which can touch every aspects of medicine. So it needs more attention to develop the subject. Thank you, Professor Dr. A.K. Azad Chowdhury, for your nice delivery. We are proud enough that we have Professor Salimur Rahman, President, Association for the Study of Liver Disease Bangladesh, among us at this very moment of 5th annual conference of Bangladesh Stem Cell and Regenerative Medicine Society. I would like to request Professor Salimur Rahman sir to say something about us.
বিসমিল্লাহির রহমানির রহিম। আমি প্রথমেই ধন্যবাদ জানাবো এই সম্মেলনের উদ্যোক্তা অধ্যাপক মামুন আল মাহতাব, আমার প্রিয় ছাত্র। এত সুন্দর একটা বর্তমানে যেটা আমাদের দরকার স্টেম সেলের উপর এত ভালো একটা সম্মেলন আয়োজন। এখানে উপস্থিত আছেন প্রধান অতিথি হিসাবে মাননীয় ভাইস চ্যান্সেলর অধ্যাপক শরফুদ্দিন আহমেদ। আমাদের এখানে উদ্বোধন করলেন মাননীয় আমাদের এক্স চেয়ারম্যান ইউনিভার্সিটি গ্র্যান্ড কমিশন অধ্যাপক A.K. আজাদ চৌধুরী, এবং এখানে উপস্থিত আছেন আমার প্রাক্তন সহকর্মী বৃন্দ এবং প্রিয় ছাত্রবৃন্দ। আমি প্রথমেই শুরু করব, এটা বিজয়ের মাস, প্রথমেই আমি শুরু করব লাখ লক্ষ শহীদ এবং মা বোন যাদের ইজ্জতের বিনিময়ে, যাদের সম্ভ্রমের বিনিময়ে আমরা এই দেশ স্বাধীন করেছি। আমি আরও শ্রদ্ধা জানাবো বঙ্গবন্ধু শেখ মুজিবুর রহমান এবং তার পরিবার, যারা এই স্বাধীনতার প্রয়োজনই আসলে তাদের জীবন দিয়েছেন। এছাড়া আমি এই অর্গানাইজারদের ধন্যবাদ জানাবো আমাকে এখানে স্টেজে এনে সম্মানিত করার জন্য। বঙ্গবন্ধু দ্বিতীয় স্টেম সেল কনফারেন্স আমি প্রথমটাতেও অ্যাটেন্ড করেছিলাম, আমাকে আহ্বান জানানো হয়েছিল, এবং এই দ্বিতীয়টাতেও আমি আসলাম এবং সম্মানিত বোধ করছি। এবং এখানে দেশের এবং বিদেশের অনেক স্পিকার স্টেম সেলের উপরে তাদের অত্যন্ত মূল্যবান বক্তৃতা দেবেন। আমরা শুনে আমাদের জ্ঞানকে আরও সমৃদ্ধ করব। স্টেম সেল একটা, আমাদের প্রফেসর A.K. আজাদ চৌধুরীও বললেন যে এটা একটা গ্রোয়িং সায়েন্স। সায়েন্স হলো এমন একটা জিনিস যেটা প্রয়োজনে, সময়ের প্রয়োজনে ডেভেলপ করে। যদি সেটা সঠিক হয় সেটা টিকে থাকবে, যদি সেটা ভুল হয় সেটা হারিয়ে যাবে। আপনারা এরকম অনেক কিছু দেখেছেন যেটা এসছে আমাদের কাছে কিন্তু হারিয়ে গেছে, যেটা সময়ের বিবর্তনে আমরা প্রমাণ করতে পারিনি যে এটা প্রয়োজন। স্টেম সেল যদি আমরা প্রমাণ করতে পারি, আমরা প্রমাণ করে দেখিয়ে দিতে পারি যে এটা মানব সভ্যতার জন্য, মানুষের বেঁচে থাকার জন্য প্রয়োজন, তাহলে অবশ্যই স্টেম সেল টিকে থাকবে। এবং আমারও ক্ষুদ্র অভিজ্ঞতা আছে স্টেম সেলের উপরে। এই করোনার পূর্বে আমরা বেশ কয়েকটা 12টার মধ্যে স্টেম সেল লিভার ডিজিজের উপর করেছিলাম। সেখানে সাকসেস রেট আমাদের 50% রোগী এখনও ভালো আছে, এবং তাদের বিভিন্ন রকম অ্যালবুমিনের প্রয়োজন, অ্যাসাইটিসের, ডায়াবেটিক্সের প্রয়োজন, এগুলো অনেক কমে এসছে, এবং তাদের যে রিপিটেড এনকেফালোপ্যাথি হতো সেগুলোও কমে আসছে। সেজন্য আমার আত্মবিশ্বাস যে স্টেম সেল টিকে থাকবে এবং ভালোভাবেই ভবিষ্যতে টিকে থাকবে। সবাইকে ধন্যবাদ দিয়ে আমার বক্তব্য শেষ করলাম।
Now I would like to request Professor Sharfuddin Ahmed sir, Honorable Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, to give your valuable comments.
Honorable Chairperson, Professor Salimur Rahman, our beloved teacher, Professor Emeritus Dr. A.K. Azad Chowdhury, Professor Mamun Al Mahtab, Professor Harisul Haq, and also the inventor of Bongovax, Kakon Nag, and other faculties, and all other students and my dear audience. First of all, I pay my deep respect to our father of the nation, Bangabandhu Sheikh Mujibur Rahman, as this is the 50th victory day was on 16th December. I also pay deep respect to all the martyrs, freedom fighters, and the people who died on Corona recently, including our frontliners. First of all, I say that in our subject, anatomy is not so interested. No people doesn't want to even hear anything, Golgi apparatus or mitochondria. Today, I am very happy that there is also a society on stem cell and regenerative medicine, and the audience are highly interested. Someday, probably 10 days back, I visited this Toti Cell laboratory. There was one Indian. And I found there that they are also collecting the umbilical cord. They are collecting the stem cells, and I have already heard that some of the German company, they are searching for umbilical cord from where this blood, they want to use it allogenic, probably stem cell. There are, in our country, still all the faculties, all the departments, they have the scope of using. In my department, that is ophthalmology, if there is dry eye, we use the some of the conjunctiva, and in the limbal region, if we place it for 2 to 3 weeks, dryness will be reduced. From my own blood, autologous serum, we can use this one, and this autologous serum will cure our dry eye. Now, few days, probably 1 or 2 months back, we had the stem cell therapy in infertility department. Jasmine was there. We have probably 3 ladies, they had got the ovulation with this stem cell. All of them are infertile. So we are giving the life to them. And this stem cell therapy in cirrhosis. Liver cirrhosis is now known to everyone of all this country people, as because one of the great leaders suffers from cirrhosis of liver. And everyone is telling she is to go abroad. Today, we can prove that I told in television that no treatment is needed outside the country. Everyone can be treated here. And in cirrhosis of liver, our hepatology department, they are giving the bone marrow cell in liver cirrhosis, and there is functioning of the liver will be increased. So we can give this stem cell therapy in liver cirrhosis. And in this way, this country will continue. This country will be richest in research. As Professor A.K. Azad Choudhury told, that in future, we will be the topmost position. Today, I told in the morning that booster dose, whether the people is needed or not, we have already started our antibody test. And we have another 6 months, there will be no antibody. So we should give the booster dose to our seniors, above 60 years, comorbid, and the frontliners. In this way, we can proceed. In my institute, we hope this type of umbilical cord should be collected. We will also utilize it, and stem cell therapy will be given in other departments where it is needed. Apheresis will be done, this transfusion medicine department, hematology department, and the hepatology, they have come forward. I thank all of them. And in future, if all the departments come forward for using this stem cell therapy, all the support from my administration will be given to all the faculties, and you should come forward. In future, we will work together. I hope this society will be a successful one. And today's seminar will be a successful one. I hope all of you will learn a lot and you will utilize it in your future patients who will be benefited from your treatment. With these few words, thank you very much for inviting me today, and thank you very much for patient sharing. With these few words, thank you very much. Joy Bangla, Joy Bangabandhu, may Bangladesh live long.
Thank you, Professor Dr. Sharfuddin Ahmed sir, for making time from his very busy schedule, and thank you for very nice, inspiring speech. Now it's time for crest distribution. I would like to request Professor Dr. Sharfuddin Ahmed to deliver crest to Dr. A.K. Azad Choudhury. Professor Dr. A.K. Azad Choudhury. Dr. Sharfuddin Ahmed sir is delivering crest to Dr. A.K. Azad Choudhury. Thank you. Now I would like to request Professor Mamun Al Mahtab Shopnil sir to deliver crest to Professor Selimur Rahman. Now I'd like to request Professor Selimur Rahman to deliver crest to Professor Dr. Sharfuddin Ahmed. Thank you all, sir, for your pleasant participation. Now I would request Professor Dr. Harisul Haq Choudhury, sir, Professor Harisul Haq, sir, Professor Department of Cardiology, to deliver vote of thanks.
Thank you very much. It's my immense pleasure to convey my vote of thanks to Professor A.K. Azad, sir, who was the former UJC Chairman, Emeritus Professor of Bangladesh. My thanks to Professor Selimur Rahman, sir, my senior teacher. Thanks to Honorable Vice Chancellor of Bangabandhu Medical University, Professor Dr. Sharfuddin Ahmed, sir, and also to my colleague, the renowned interventional hepatologist, Professor Mamun Al Mahtab, for arranging such a beautiful seminar. Thank you very much for your presence and patience. Thank you.
Now I would like to request Dr. Faiz Ahmed Khandokar to continue scientific session 1.
So we are left with the third speaker of the first scientific session, Dr. Mohammad Munir Jaman will now speak on bone regeneration, hype or hope. I'd like to request him to start the delivery.
Honorable Chairperson, my distinguished delegates and fellows and students. Assalamu alaikum wa rahmatullah. It's my immense pleasure to be here, especially as an interventional physiologist when I'm talking about the regenerative medicine regarding the musculoskeletal field. I feel actually enjoy in front of the, especially in the Milan Hall, the BSMU. Now, my conflict of interest is no, and today's topic is bone regeneration, hype or hope. So, the already our previous presenter already said that actually we are not clear about the efficacy of the stem cell or the effectiveness. So, is it hype? The hype means actually the over advertisement to create the excitement or interest. You know, the already about the different business company of in our country, about the over advertisement. So, if we look about the history of our victory, it's the evidence and the long scenario and the last declared by the Harbang Udu Sheikh Mujibur Rahman. So it's a strong history and evidence. Like the regenerative medicine also, it is not a fake. It's actually started from the 1909. The Alexander Maximo, he actually the first identified the single precursor cell within the mesenchymal, which gives rise to all types of blood cells. And then 1970, the discovered embryonic stem cells in murine blastocytes. The 1970, the Alexander Friedstein, the colony forming unit factor, growth factor documented osteocytes. And then 1989, the Mario Capici and others, they create the chimeric mouse by actually disrupting the gene sequence. Then 1997, they invent the somatic cell nuclear transfer technology. They formed the cloned mammalian, everybody knows. And then 2006, they actually invent the induced pluripotent stem cell and also got the Nobel laureate. And 2008, 7 and 8, they also used induced pluripotent stem cell and generate the neuronal precursor cells. 2010, the Deepak Srivastava, they also invent the mouse cardiac fibroblast into the functional cardiomyocyte. Then lastly, the Mitalipov, they also they find out the fibroblast nuclear transfer and the somatic cell nuclear transfer technology. So it's actually the long history, and by serial the many scientists already got the Nobel laureate. We are actually not scientists, we are physicians or surgeons or the interventional physicians, those who are actually dealing with the clinical applications, diagnosis and treatment and management. But it actually needs for the teamwork, the scientists, biotechnologists and also other persons. Now regarding the hip or the bone regeneration, especially in the hip, I want to talk. It's actually the presented in the Orthobiology Institute in the USA 2015. They actually presented about the comparison, the total hip replacement and the BMAC, that means bone marrow aspirate concentrate, for the 18 cases and 24 cases. They actually compare and found that after 1 year, in both cases actually total hip arthroplasty, the Harris hip score, that means increase from the 56 to 94 and also the 68 to 82 in the BMAC cases. So both actually improve, and but regarding the performance or clinical or functional performance, the BMAC case actually more improved than the arthroplasty. But the immediate pain relief is actually arthroplasty cases. But regarding the scenario of the complications, the BMAC is more safer than the arthroplasty, like the DVT or the joint infections or the nerve injury or the leg length discrepancy or even the cost, and also the revision surgery. Now the regeneration. What is regeneration? Actually regeneration is the process of creating the living functional tissues to repair or replace tissue or organ function lost due to the age, disease, damage or congenital defects. And the stem cell, the terminology about next step, it actually has no self-renewal capacity. It actually differentiates into the mature cells or the specialized cells. And the stem cell potential of the plasticity, that is actually ability to differentiate into other cell types. And that one article, the stem cell therapy for treatment of hip posterior necrosis, the 30-year review of progress, they mentioned the injected bone marrow actually the repopulate the trabecular bone structure and the subsequently revitalize and the remodel the necrotic bone. And in the Davidson, they also they write the stem cell plasticity may have the exciting clinical applications in the future. And in also the Naples, while the bone contour is intact, there remains the hope that structural failure can be prevented. And some recent evidence also raised the femoral head collapse can be reduced through augmented with mesenchymal stem cell. So it's actually the bridging treatment between the conventional treatment and the surgery. And we have the 4 types of stem cell, the ADA stem cell, and the embryonic and the induced pluripotent stem cells. The mesenchymal stem cell commonly called the adult stem cell. So we deal with this. It's actually remain quiescent in our body, and actually it stimulate when actually it's need. And the autologous bone marrow concept is actually our mostly interest because it's no risk of the genetic transmitted disease or the minimal cell manipulation. And it has ability to differentiate into the chondrocyte by fibroblasts or the other muscular tissues, and among this and the chondrogenic and osteogenic transformation capability is more than the life of spirit. Now the other else beyond the stem, before the stem cell, that means PRP, you know that is the tip of the iceberg, the regenerative medicine. It first collect the blood and then we process and ultimately the latest generation PRP is the platelet lysate. We actually breaking the cells and also the only collected the concentrated growth factor and then we inject. And also the viscous supplement has some role for the regeneration of the cartilage. Now I want to talk with some scenario for before the bone regeneration. Actually, the bone regeneration come when the bone necrosis actually when we deal with the treatment. The scenario 1, please look at I draw attention to the audience some case for I expect if you give the answer. The 13 years female, the known case of ACD for 4 years, the right hip pain for 3 months. The X-ray is actually normal. Then MRI shows the bone marrow edema. So, is there any confusion regarding the diagnosis? Anyone? Actually, this is the avian definitely, but as the X-ray is normal, you see, but the bone marrow edema present only the hip pain. But as patient ACD, so she has taken history of the long time steroid or repeated steroid high dose. So actually, it's commonly expected, and this is a stage 1 avian hip. The scenario 2 is you see the 25 years female, the inflammatory low back pain for 3 years, both hip pain 6 months, and the X-ray also shows the density and decreases the joint space. And MRI shows the bone marrow edema and also the osteonecrosis in the both sides. Left side is more than the right side. So it's also the avian hip, but as patients have the inflammatory low back pain, so its patients have also the SP axial spondyloarthritis with axial variety. It becomes stage 2 to 3 in the left side and right side 2. And also that for the decreased joint space, secondary osteoarthritis is also developed. So we have to work in all these issues. The scenario 3 is 55 years male patient having the left hip pain for 1 year and also is a single joints. The patient also the cases also the post-traumatic or post-surgical repeated steroid like the asthma, bronchial asthma, chemotherapy or the beautification by the
recording
steroid
in
or
progress.
Chronic arthritis, the hip trauma or surgery, especially if it's not managed within the 3 to 6 hours, and also the post-bleed or the post-septic. And we also categorize the different staging like the FICAT alert staging or the Steinberg's classifications. The indications is actually the stage 1 or 2. And today's next actually the methods to regenerate, the how and what and where. how that means the intraarticular or the surgical delivery. Actually intraarticular it's need stage 1 and 2 we are actually practicing, and 3, 4 actually needs the surgeon for the surgical delivery, and both way we can actually inject the stem cell. The what the concentrated or expanded, it actually later I discuss, and the where from the bone marrow or the adipose tissue, synovial tissue or the peripheral blood. The already our the inaugural sessions already Professor A.K. sir said the many publications already is published, and you see in 2013 actually tremendously actually increased the number of publications, and you see the intra-articular injections already the before 2012 the 21 publications and the surgical 15, and the BMAC on the BMSC the 16 and DMSC the 9 publications. The more research actually going on the BMAC, and the two sources we have an interest, adipose tissue and BMAC, and the constitution and expanded. There is a we have working the two issues, but the so we actually go in the OT. That is need the sterile, the full phase technology, and the, you know the adipose tissue derived stem cell we collect from the lower uterine fat, and the different the company derived the kits they invent, and they actually promote us to use the stem cell derived processing, but the BMAC is I already mentioned is the more chondrogenic and osteogenic actually the preponderance to develop the osteoblast. So the BMAC is collected from the posterior iliac spine, and it's actually the we use the aspiration needle of the trocar or the by drilling technique. And firstly we use the epidural of the spinal anesthesia for the pain relief procedure and pain free procedure, and the sono guided we collect the stem bone marrow aspirate actually we collect from the posterior iliac spine, because we collect about 50 to 100 ml the huge amount of concentrate, so it's need the wide bore actually 11 gauge Jamshidi needle, and the sono guided it's avoid any double puncture or any complications. So ultimately we actually we use actually the 10 cc or 20 cc series rather the 50 cc for the minimal cell manipulation, and then after collect the blood the bone marrow concentration, then we use the different centrifuge machines, and after the centrifuging actually the process the BMAC concentrate, and on the MSC is processed. Then the MSC and processed, then we actually plan for the how we inject the hip, because it's another technology or the expertise is need by the CM biplanar fluoroscopy technique. First we actually see the AP and lateral both view. We have to cautiously process by introducing the trocar, because there is a chance of we reach just behind the subchondral area in the necrosed area, and you see that in the right side this is a bone marrow edema. We have to cover the inferolateral and the inferomedial and the superolateral area of the head and neck. So in the neck we also inject the PRP or lysate and the stem, and also in the head you see the another approach, another side to superolateral area we also inject the BMAC, and by this way some core decompression also occurred, so it is also help for the bone regeneration and the relieve the interosseous pressure. Another case you see in the left side, you see the little lysate, and also, and lastly we also inject in the joint also sonoguided, because the hip arthritis or the degenerative process already changed, then we also try to regenerate the cartilage, and it can be injected anterior or lateral approach. You see in the before stem cell and after 3 months there is a 80% bone edema already reduced, and also the patients have also the range of motion also improved, and also the WHOOS score, that means hip disability and osteoarthritis outcome score also improved after BMAC. And this also presented in the 2020 ISPRM, and also, and the another case also after 3 months, this is an inoperable case of the post-traumatic the hip. You see after giving stem after 3 months there is increase space, and also the decrease the density. So at the high level actually we do not work at the scientific level, but this should be need in the teamwork. So we are actually not ready for metal, and we try to avoid for progressing the stage 3 and 4 from the 1 and 2. Now the rehab, just one slide, rest for the, after procedure, there are 3 weeks and the absolute bed rest and the crouch walking, use non-weight bearing and the walking with the hip orthosis, and also we give the hip strengthening, girdle strengthening and the quadratus hamstring strengthening exercise, and lifestyle modification and activities of daily living. And the new minimal invasive procedure also invented. It's also published in the journal, the International Cartilage Regeneration Society. They published the hip distraction by the hip, the external fixator. They shows that after 3 months using this hip distractor, they increase the space and relieve the pressure, and also the stem cell also preserve and active more. So the stem cell risks actually, my stem actually the very few, but the more the expansion at the lab are induced, there's a more risk. And there is actually also accepted in the regulation board by the regulatory body in the USA also. And the global stem cell activity, the whole world, right, actually the USA, Canada and the Europes and the Australia and the Japan, South Korea, they are practicing. And different country have the different actually regulatory body and the protocols. And I am actually working in the, this is, I was trained, sorry, due to lack of institutional facilities, I have to work in the private setting in the Popular Medical College. And in the, I was, these are pictures of my training in the USA. This is actually become the American Board of Regenerative Medicine diplomat. So I just one slide shows how to become the diplomat. First, you have to American Academy of Regenerative Medicine. You have to become the associate member. Then you can become the active member after 2 years. And after certification course, you have to appear the board exam. Then you can become the diplomat. And for standardize the knowledge, the ABRM actually certified the whole world, the physicians and surgeons. Now my home message is actually don't delay to start treatment in early AVN, at least hip unloading brace and ADN. If patient can allow or able to do the stem cell procedure, the selected cases stem cell intervention has a hope and rewarding. And stem cell preservation and getting benefit is very much important by rehab. And the save your hip till the life expectancy. This is actually the Herbert Henry Asquith, the former British Prime Minister, said actually the youth would be an ideal state if it came much later in life, and by the stem cell you can enjoy this youth status in your real life. So this is my email address, and if you want to contact with me, and this is my the victory day. Thank you very much.
Thank you, Dr. M.M. Jaman, for your brilliant presentation on bone regeneration by stem cell therapy. So we are at the end of our scientific session 1. All the 3 speakers have presented their delivery. And now it's a short question and answer session. If you have got any questions, we can take, and our speakers will reply. A microphone, please. As because we are running behind time, we will take 1 or 2 questions.
Thank you. Thank you for the brilliant presentation of the 3 speakers. My question to first and the third speaker: you are using the bone marrow stem cells. So how you are differentiating from the hematopoietic stem cells to the mesenchymal stem cells? So do you do any flow cytometry or any marker test? Or how then you will actually in the laboratory, you have to expand the stem cells. So how do you do that? Yeah. So any of one of the first and the third speaker may answer. Thank you.
Thank you, Dr. Mafrua. Actually, we don't expand in the lab or the outside the body. We just, after making the concentrated mesenchymal stem cell, then we inject into the target area. This is our actually process. But regarding the cell counting,
My first question is that how do you identify the mesenchymal stem cells and how do you differentiate it from the
making the study by using the kits, they have the mostly the mesenchymal stem cell by this way you can process. So we can actually And another thing, the BSM, the microbiology department, we send the sample, about 2 cc or 3 cc of the collected or the processed BMAG MSC. They actually give us the counting, how many actually the cell count, the factors, CD4 marker or CD8 marker actually collected in our sample. So by this way also we can actually take the satisfy myself and also patient. Otherwise actually we have no extra facilities.
Actually, yes. Still this is confusing to me.
Okay, let me say. There is peripheral stem cell. They use cancer growth factor for 3 to 5 days. Before that, they count CD4 or WBC count. In microbiology department, they have their kits to validate the CD4 count and viability. Dr. Sheet is doing this. Another way, they take from stem cell from the peripheral blood, not bone marrow. Bone marrow is 2 sources. One is mesenchymal blood, one peripheral blood. So they use some drugs. There is a specific dose, 4 to 5 days. Before that, they go for the CD4. After that CD4, then you collect. There is a kit. There is a apheresis machine.
Is it CD4 or CD34?
CD34.
So CD34 is the marker for the hemopoietic stem cells. So you are using, in that sense, you are using the hemopoietic stem cells.
Yes.
So they mentioned about the mesenchymal stem cells.
They have used mesenchymal stem cell, but Jasmine used PBSC, not mesenchymal stem cell.
Okay.
That's why she used growth factor. There are 2 drugs. Healthcare system has some drug. They have body weight, other factor. They select the dose. They use the dose intravenously 3 to 4 to 5 days. Before that, they go for the WC count or 334. After that, they go for that. Dr. Sheen is doing the viability test as well as count. Then we collect our apheresis machine. There is the kit only for PBSC. There is the kit only for cord blood. Nowadays, in 52 blood center, there is a apheresis machine to do this. Either they will collect stem cell, mesenchymal cell, there is a special kit.
So the question to you now, how do you separate the mesenchymal stem cells?
I understand, but actually when we process or the centrifuge, then the kit supplying company, they mentioned actually the BMAG MSC. But we are actually, we are not hematologists or the scientists. But in the foreign country, they actually work with the scientists. They collect the sample, the physician doing this job like me, and the scientists actually they give the certified or their research and the published journal like this. So we are actually
I got
not
your
expert on
point.
this.
So
Yes.
you do not know what you are using. You assume that you are using mesenchymal stem cell. Thank you for your clarification. May I ask a question to second speaker? Is he online?
Endothelial progenitor cells and few terminally differentiated cell. So it is heterogeneous population, but in that population we have mesenchymal stem cell and hematopoietic stem cell for stromal vascular fraction. And for hematopoietic stem cell bone marrow aspirate concentrate, the number of hematopoietic stem cell is more, but there are mesenchymal stem cell as well. To specifically identify the number of population, we need to do flow cyto.
That's why I'm asking, how can you differentiate? Because he is using the mesenchymal stem cells, not the
actually
hemopoietic stem cells, because hemopoietic stem cell will not grow as a bone cell. So that will not be working in the avian. But mesenchymal cell definitely will do for that.
In avian, actually here, as it is heterogeneous population, his target is to support the differentiation of mesenchymal stem cell into chondrocyte or osteocyte, whatever it is. He is getting the support from the heterogeneous population. Meanwhile, actually we need to work on the it is actually a pro-inflammatory condition, so we need to create the inflammatory condition again, and to do that, we need the support of hematopoietic stem cell as well. So it is, first of all, it is autologous, it has no harm to use, and second of all, it has those population that can help support us in immunomodulation, and it can support for regeneration.
Do you have a minimal level of cells or count of the cells of the mesenchymal cells that is working or that is needed to work?
For stromal vascular fraction, almost 25% population is mesenchymal stem cell.
That is my question.
Yes.
How can you be sure that at least 25% of the mesenchymal stem cells are there in that population?
We have no way. We have to do flow cytometry. We have
Without doing flow cytometry, they're doing it.
Yes, doctors are practicing these on the basis of previous data that others, the report we have available, that on the basis of 100 of trials, 100 of reports, actually there is a range that in that population, how many cells will be mesenchymal stem cell, how many cells will be hematopoietic stem cell. So it is the range only. But who have, in our lab, we have flow cyto, so we can actually specifically say that in that population, in that sample, we have this much of mesenchymal stem cell, we have this much of hematopoietic stem cell, and this much of endothelial progenitor. We can say, because we have flow cyto.
But you are not using flow cyto in clinical practice, right?
Actually, it is, I'm representative of TOTICEL. We will give the certificate of analysis. Whoever want to do, whoever want to practice, whoever want to use our facility, we will provide the certificate of analysis.
Okay.
Thank you very much.
May I ask a question of the second speaker that you mentioned you will answer?
Yes, I'm on behalf of him.
So CAR T-cell is very much effective for
he is also in
hematological
online.
malignancy.
Online outside.
So when it will be available in our country, I really appreciate your effort for CAR T-cell, when it will be available in Bangladesh.
Yeah. Can you hear me?
Online outside.
Hello, can you hear me? So those vector will have a actual patient-specific mutation, especially the cancer mutation-related construct should be there. So we'll be making a chimeric receptor, and that chimeric receptor will be able to bind that particular cell type. So for that, what we need actually molecular analysis of the patient samples. So what type of mutations this patient is carrying. Second is we need a viral vector design. Even it can be even non-viral also. So that is a cloning procedure. So the cloning is we can do this cloning. So only that what we need another GMP facility for virus productions. So once we know that patients, what is the patient's genotypes, and this can be done easily. We have a lot of molecular biology lab in Bangladesh now. We can easily identify the mutations, and based on that, we can make a chimeric antigen receptor, and you can clone it in the virus, and then virus has to be produced in the GMP facility. Once it's done, then we can actually infuse these cells directly into the patient's body. So now question is what we need. We need actually just another GMP facility for virus production. So it may be 1 year or even 1.5 years maximum. So we will be able to produce our CAR-T in Bangladesh.
Okay.
Even more faster, I guess.
But the question is that I didn't ask about the procedure. I asked you about when the CAR T cell is available, will be available in Bangladesh, because this is very much expensive. In first world countries, they are using it for heme malignancy. Even after bone marrow transplantation, CAR T cell are using. So when it is available, because Bangladesh, do we have any lab that can produce or that can able to produce CAR T cell?
Why I tell you that is without GMP, non-GMP grade CAR T, we can make it. We have the ability, we have technology. But only that we need to make another GMP grade facility where the virus production will be in a pharma grade.
Yeah.
So I'm talking about that. We need to plan for that facility. So it may take, because with this we haven't started anything yet. So if you want to say that, okay, if you are non-GMP grade, so it will be, we'll start working when.
Okay. Thank you, madam, for your questions, and also the speakers who answered them. Now, as we are running short of time, now I would like
For bias
to
production.
request
This is the
some
time only for
comments.
infrastructure development that we need.
We would request some comments from our chairpersons. First, I would like to request Professor M.S. Salek, A.K.M. Salek. He's the chairman, Department of Physical Medicine and Rehabilitation, to deliver some comments.
Assalamu alaikum. I was amazed and I was listening to the deliberation, but I missed the first deliberation of Professor Jasmine, but I knew her work, but I have gone through the presentation by Zakir Hussain and Dr. M.M. Jawan. Stem cell, as we know, it is not any specialized cell, but in time of need, it can be converted into a specialized cell, say muscles, cartilage, hematopoietic cell. This is the stem cell, as we know from our knowledge. So this cell, at the advent of our paradigm shift of the treatment in nowadays in NCDs, there is a lot of scope of applying these cells. So from hair root to feet problem, there is scope of using this stem cell therapy and regenerative medicine. And if we, otherwise we say it a translational medicine, whatever. But thing is that the scope and its jurisdiction. So as we know, wherever there is a R&D, after R&D there is a lot of scope of its application for the betterment of humankind. But as well as we have to be very particular and pertinent to the issues related to the ethics. That is one of the question. This ethical application is one of the prime and paramount importance. We should be very certainly, we should keep it up. So still there are some ethical dilemma and issues regarding this, as it is a totipotential cell or whatever as cells of having capability to differentiate into many particular type of cells. So these ethical issues should be very clearly defined. And as still we are in dilemma, it will be one of my, as I need, and I would like to request to our researchers, our young scientists, whoever in front of me. I know many of you, you are having projects you are doing and you are having good results, as I know. But I would like to request and I would ask the authorities to be the patron and for its betterment and flourishing this medicine, it is to be institutionalized rather than personalized and in practice. So institutions should come forward for this field rather the persons. So I would like to, I am asking everybody to be very pertinent in this field and to carry out research, and hopefully we will have the better outcome of this effort so that it can be used for the betterment of mankind. Thank you.
And now final comments from Professor Asadul Islam, Chairman, Department of Transfusion Medicine, BSMMU.
Dear participant, honorable guest, and honorable speaker from Human About, large audience, my heartiest thanks to the organizer to invite me as a participant, as the chairman. This conference gives us the information that we are in the advancing way in stem cell. Actually, we are a people of transfusion medicine. So in our field, it is just whole blood. We are collecting whole blood, we're collecting bioprocess machine, RBC, we're collecting granulocyte, we're collecting stem cell. That is in our part, and we are product liable. That's why in our center there are 8 apheresis machines, and throughout the country 52 apheresis machines now. And in 2001, government has a plan for dengue to buy 4 apheresis machines. Then we have a meeting. We will not disclose this to the ministry. That from this machine, we can use 40% disease we can treat by apheresis machine through plasma exchange, stem cell therapy, and others. We know Vice Chancellor says that Toti company cord blood. There are 3 sources from stem cell. One is peripheral blood, one is cord blood, one is bone marrow. Through peripheral blood, we have to mobilize, then it comes to the peripheral blood, then we collect it, our apheresis kit, then either we use it either intravenously or locally. That's been used this as there's some factor. In case of cord blood, Vice Chancellor said that he said, but cord blood you can collect in ex vitro or ex vitro. Previously it was collected by a jar, then syringe, then bag. Nowadays there is a apheresis machine and apheresis kit. We can use by kit we can collect maximum 40 to 140, that is 100 ml. In case of peripheral stem cell, we need only mobilization, then patient preparation, then collection, then transfusion. But in case of cord blood, we have to go for the RS typing, then isolate typing, then antibody screening, and other tests as per needed. So I think that we have a fear about the stem cell and cord blood. As blood bank expert, it is just like whole blood, just like RBC, just like plasma exchange. There is a modern science, there is a apheresis machine, there is a sophisticated machine, there is a kit for the cord blood, kit for the peripheral blood, and if we save the bone marrow, then we have to sort something about the collection. We have to collect it from the iliac crust, just like operation. There is a mini puncture, then we have to separate the sibling, the bone, fatty globules, then purging, then go for meshing. That is the operational procedure. This is our part. And people who use the stem cell or cord blood, they have their own idea. Then at present, in previous way, Swapnil and Dr. Anwar collect 76 stem cell from our center, they use this. And Jasmine is doing this, she collect 5, and others, medicine, they are using cord blood in post-COVID lung fibrosis. And cerebral palsy, the peri-nephrology, they are talking with me, they want to use stem cell for cerebral palsy patient. And the orthopedic center, the NITOR, they talk with us, in spinal injury, they want to use stem cell. So I think in this way, stem cell is in progress now, and now we are thinking about the cord blood. You rightly mentioned that when we mobilize the stem cell, then we have to check the viability and collection and number. That's why Dr. Salek Bhai said we need a guideline. We need a structure way. Every private clinic, they are using PRP, that is platelet gel. This is called platelet gel. They are using this. But we should have a guideline, how we collect PRP, how we use this is the time to make a guideline of the PRP. I think this conference will make us more knowledge, and we will reach our knowledge about stem cell, peripheral stem cell, cord blood stem cell, and how we collect, how we process. And I think this conference will remove fear from our mind. I think as it is, what are we take from the tap? In our blood center, we collect whole blood, we collect RCC, granulocyte, leukocyte, we collect stem cell as usual. In our center, it is our technologist, they can collect stem cell. The question, how you use. If it is autologous, it is no problem. It is allogeneic, then you have to go for a slide procedure. I think it will discuss later. The time is short. Thank you all. Thank you very much for our passengers.
Thank you, sir, for your valuable comments. Now I would like to request the speakers of this session to come up in the dais and to take their memento from our chairpersons, Professor Jasmine Banu and Dr. M.M. Jaman. Please come up in the dais. Jaman আর জেসমিন মানে স্পিকার ওইটা না এটা হচ্ছে
এটা নামটা উল্টে গেছে
Now I would like to request Professor Selimur Rahman sir, President of ASLEB, to come up in the dais and to present the memento to our chairpersons.
Now hand over the case to Dr. Faiz Ahmed Khandakar by Professor Selimur Rahman.
Thank you.
Now we are going to start scientific session 2. This session is moderated by Dr. Sheikh Mohammad Noori Alam, Associate Professor, Department of Hepatology, Bangabandhu Sheikh Mujib Medical University. Dr. Sheikh Mohammad Noori Alam, please come to the dais.
Assalamu alaikum. This is Dr. Sheikh Mohammad Noori Alam from Department of Hepatology, Bangabandhu Sheikh Mujib Medical University. We have three speakers. Dr. Mahroufa Akhtar, Assistant Professor, Department of Hematology, Dhaka Medical College. She will talk on status of stem cell transplantation in Bangladesh. Professor Mamunal Mahatab Shopnil, Division Head, Interventional Hepatology Division, Department of Hepatology, Bangabandhu Sheikh Mujib Medical University. He will talk on autologous hemopoietic stem cell transplantation in decompensated cirrhosis of liver, experience from Bangladesh. And Dr. Moshiur Rahman Khosru, Associate Professor, Department of Physical Medicine and Rehabilitation, Bangabandhu Sheikh Mujib Medical University, will talk on outcome of single intra-articular injection of adipose tissue-derived mesenchymal stem cell in knee osteoarthritis. The session will be chaired by Professor Selimur Rahman, former UGC professor, Bangabandhu, and former professor, Department of Hepatology, Bangabandhu Sheikh Mujib Medical University. I'd like to invite sir to take on the dais. And I also invite Dr. AVM Adnan, Associate Professor, Cox's Medical College, to co-chair this session. Dr. AVM Adnan from Cox's Medical College. Our first speaker is Dr. Mahroufa Akhtar, Assistant Professor, Department of Hematology, Dhaka Medical College, and she'll talk on autologous hematopoietic stem cell transplantation, status of stem cell transplantation in Bangladesh.
Thank you, Mr. Moderator, Honorable Chairperson, Co-Chairperson, and learned audience. I am Dr. Mahroufa Akhtar. I welcome you all to Worldwide. It was started in 1956. The first bone marrow transplantation was done for a SCID or immune deficiency patient, and it was successful, and that's why Edward Donald Thomas, who is known as the father of bone marrow transplantation, he was rewarded Nobel laureate in 1990 for saving many lives of lymphoma and leukemia and hematological diseases for doing this bone marrow transplantation. So next 10 minutes or 12 minutes, I'll be talking on these topics. First of all, I will give a highlight of the basic concept of the HSCT. So for which I have no conflict of interest to declare. So what is bone marrow transplantation, or what is hematopoietic stem cell transplantation? Actually, these two terms are used synonymously, although the source of the stem cells are from the bone marrow. If it is harvested directly from the bone marrow, the term is used as bone marrow transplantation. But basically, this is bone marrow transplantation is also a hematopoietic stem cell transplantation. So this is not a surgery, as you have seen that in case of the previous speaker have shown that he made some procedures. But hematopoietic stem cell transplantation is not a surgery at all. This is the infusion of the stem cells which were collected before either from the patient, that is called the autologous stem cell transplantation, or from the allogenic donor, which must be matched donor, like 100% donor matching. If it is matching, obviously, that is very good for the patient. So first of all, I may show you the stem cells are collected, because the patients of the hematopoietic stem cell recipient, they have to go through a very long process, a complex process, and post-transplant care and complications are very, very complicated. So first of all, they are collected, the stem cells, by apheresis technique or directly harvested from the bone marrow. Some of the diseases that are only have indication for collecting the stem cells directly from the bone marrow, that gives some advantages regarding the GVHD and graft failure lysed. That's why the DMSO is only used. And then in between that time, the patient or recipient is given very high dose of the chemotherapy, is known as the conditioning chemotherapy. Such a high dose of chemotherapy, the aim of the stem cell transplantation is to allow the patient to receive this kind of high dose of chemotherapy, which can be lethal unless it is supported by stem cell rescue or stem cell infusion. So either from the autologous source or from the allogenic source. So that is the type of transplantation, the autologous stem cell transplant and the allogenic stem cell transplantation. And the source, you can see that either from bone marrow, that was used in very early period, but nowadays, like after 1990s, Most of the stem cells are used from the peripheral blood that is known as the PBSC that our previous chairperson he mentioned about. The PBSC is usually collected from the patient or the donor given to invite the stem cells, the bone marrow stem cells to come out to the peripheral blood so that it, and we usually check it for, so blood is checked for the CD34 count. When it is adequate level, we collect the stem cells, like in 4th or 5th day. If the bone marrow is not enough regenerating for the stem cells, like in patients who were treated before with severe chemotherapy or some other drugs that may suppress the bone marrow, in that case we use some other medicine known as the Plarixafor. That is a very highly expensive medicine. We do not usually use it, but only use when the first line growth factor induced stem cell collection is failure. Then if we see the donor, our allogenic donor must be matched. 100% matching is desired. Syngeneic donor is the ideal donor, but it is not available, readily available in the world. So syngeneic means that identical twin, which is really rare. So matched sibling donor is expected, which is like these are 25% of chance that you may have a sibling matched, 100% matched HLA sibling donor. But in case of short family or in case of family they don't have any kids more, so they have to rely on the match unrelated donor, which actually we need to see the HLA pattern for the recipient and the donor pattern. If it match 100%, that is 10 on 10 or 12 on 12, then it is called the matched unrelated donor. But as because the transplant procedures are improving day by day, so haplo-matched donor are now acceptable because 50%, 50% matched donor, they have some more complication than matched sibling donor and matched unrelated donor, but still they are accepted because lack of matched donor. So haplo means 50% donor. Your parents may be your haplodonor or your kids may be your haplodonor. So any other brother or sister may be haplodonor. At least 50%, doesn't mean 60 or 70. That may also be regarded as haploidentical transplant. Asia Pacific Bone Marrow Transplant Activity Survey in 2014, we have observed that due to improvement of the supportive care, allogenic transplant, what is known as the more complicated one, or the complexity is more than the autologous, these allogenic transplant are rising day by day, because every year many countries are doing the allogenic transplant more than that of the autologous transplant. So the question is, why bone marrow transplant or hematopoietic stem cell transplant is necessary and for which disease? Like this is a 50-year male banker suddenly developed body ache and weakness. He was found to have pathological fracture. As you can see, it was fixed by orthopedician. Finally, it was diagnosed as a case of multiple myeloma, and he was on chemotherapy, and his status of post-chemotherapy was he was in remission. Then what is next? The question is it enough to give chemotherapy and post-chemotherapy remission for multiple myeloma? So if we see the research and the study and the two-arm like RVD chemotherapy, which is the targeted chemotherapy, or novel agent using chemotherapy versus autologous stem cell transplantation, we can see that transplanted arm did better in terms of the remission status, in terms of very good partial remission, and also in terms of MRD negativity was higher in transplanted group. So it is no question that many times it may be a matter of debate, but in case of myeloma, all eligible patient should be transplanted upfront for the better quality of life. And this was that patient that I mentioned earlier. With his permission, we gave his photograph. And he was the first case of autologous stem cell transplantation, or first ever bone marrow transplantation in Bangladesh, that was held upon 10th March 2014. And I want to share you that patient is still in good remission status, and he is doing his job. And here you can see our Professor M.A. Khan sir, who was the pioneer in the bone marrow transplantation in Bangladesh, and at that time the director of Dhaka Medical College Hospital, Brigadier Mustafizur Rahman, with the patient. Another case history, he was an 18-year-old boy of diffuse large B-cell lymphoma, advanced stage. He was treated with CHOP 6-cycle chemotherapy, but he unfortunately relapsed after 1 year. And 28-year male Hodgkin's lymphoma, who was again advanced stage disease. He was treated with the AVVD, the standard chemotherapy for the Hodgkin's lymphoma. But at the end of the chemotherapy, the PET scan was still positive for the significant, which signifies that the active disease was there. So he was regarded as the refractory Hodgkin's lymphoma. So what is the option for these two patients, like relapsed and refractory Hodgkin's or non-Hodgkin's lymphoma? So I'm not talking about the first-line therapy. I'm talking for those patients who are very unfortunate for relapsed or refractory. Back in 2009, when I came to hematology, I saw many patients dying for relapsed and refractory Hodgkin's lymphoma, or they had to go abroad for transplant. So answer is very simple. Answer is autologous stem cell transplantation, which is the standard of care for relapsed and refractory chemosensitive lymphoma, whether it is Hodgkin's or non-Hodgkin's. And this is the boy. He is still enjoying very good quality of life and a remission status. He is doing his, he was a student at that time. Now, 2014, he was a student. Now he completed his university life, and he is doing a job, and very good family life he is maintaining. So that is the beauty, and that is the strength and power of the autologous stem cell transplantation. Another case of allogenic transplant that was held in very first allogenic transplant in Dhaka Medical College Hospital. She was a mother of two young children, 29-year female, who was the Philadelphia positive ALL, which is regarded as very high risk ALL, or acute lymphoblastic leukemia. She relapsed after chemotherapy, but she was very fortunate to have a matched brother who was 100% matched, HLA matched, and he donated the stem cells. The stem cells were collected from the way our Professor Asad sir mentioned, that 4 or 5 days we give the growth factor and we collect the stem cells, and at the same time when the patient is going through a very high dose of the chemotherapy, that is conditioning chemotherapy known as the busulfan and cyclophosphamide, and at the same time patient was given tacro and methotrexate as GVHD prophylaxis. And as I am telling about this process, sounds very easy, but for the patient it is very hard, because 10 or 15 days or even more than that, the patient's neutrophil count, platelet count all become down to 0. So all this we need to support her through antibiotic, antifungal, and the environment we have to give. So this is not an autologous, this is allogenic transplant, which makes the patient myeloablative. So there is no way to, if suddenly, if the donor dies or something unexpected happen, definitely this recipient will die, because she is now totally dependent on the stem cell support. So unless the stem cell is supported, this patient would die definitely. So such a high dose of the chemotherapy is given just to kill her disease. Her deadly disease is to kill. And good thing is that patient had 100% achieved, she achieved 100% donor chimerism on day plus 28. And we have seen that our patients, she is still in remission and doing, she is going back to her family and running her family as a mother. So all about, I have discussed about the indication of the stem cell transplantation. For autologous stem cell transplantation, chief indication is the multiple myeloma and the relapse and refractory lymphoma. But some of the lymphomas, very high risk mantle cell lymphoma that can be regarded as an indication for upfront autologous stem cell transplantation. For acute myeloid leukemia, those do not have any matched donor. Sometimes we may try with the autologous stem cell transplantation that we have tried for one patient, and one of our AML patient, he is now great student. He is very good maintaining his remission. But this is not an ideal one. Ideal one is the allogenic stem cell transplantation because he was the only child of his parents. So acute myeloid leukemia high-risk cases, acute lymphoblastic leukemia, myelodysplastic syndrome, severe aplastic anemia, and thalassemia major, E-beta thalassemia, they are the indication for the allogenic stem cell transplantation. So now I'm talking about how many centers of Bangladesh they are doing the HSCT. There are rightly 5 centers, including first of all the Dhaka Medical College Hospital. They started their activities in 2014. Later on Evercare Hospital and CMH Dhaka in 2016. And this BSMMU hospital started first transplant. I don't know you already informed or not. So 2018, one bone marrow transplantation for a myeloma patient was done in this hospital, and Asghar Ali Hospital. They started their activity in 2020. So this data I have compiled every year. We do this for January and June, and so this data was compiled in the September this year. So overall status of HSC transplantation in Bangladesh was total 135. That is continued data, so it is now may cross the 140 or something like that. So 80% or more for the autologous stem cell transplantation, and the majority of the cases were myeloma, non-Hodgkin's, relapsed refractory non-Hodgkin's lymphoma, Hodgkin's lymphoma, and we have done few cases for the allogenic, for AML, ALL, and some other diseases. And institutional-wise, if you see DMCH, Evercare, CMH, BSMMU, and Asghar Ali Hospital, average age of all patients is 41 years, male-female 5:1. And that is, I have talked about the myeloma and NHL are the main cases. And the engraftment, which is most important, the stem cells that we infuse the patient, it must give rise to new cells. And whenever it is giving adequate cells, that is the period known as the engraftment period. So it has some cell count marker, but neutrophil day plus 10 average, and for platelet day plus 12. So you can see that at least 10 or 12 days, these patients are severely neutropenic sepsis, and so many complications may arise. But fortunately, for all our centers, the transplant-related mortality within 100 days is 0 for the autologous stem cell transplantation, but for 7% for the allogenic transplantation. For worldwide data, autologous stem cell transplantation, the transplant-related mortality is less than 5%, but for TRM in allogenic transplant is quite a bit high. It depends on many factors, age, disease status, and so many things. So now individual institutions see the data, and if you can just look upon the colors, different colors indicates that different diseases. The Dhaka Medical College Hospital so far did the 52 cases of the transplant, among them 47 autologous stem cell transplantation and 5 allogenic transplantation. Okay, thank you. So among them, patients are alive with CR in 61%, not bad, but alive with progression and 12%, and 12 patients died in last 6 years. This is not the 100%, within 100 days mortality. But for allogenic transplant, 2 patients only are alive. I have mentioned that the complication of the allogenic and autologous stem cell transplantation, this is very, very severe. And if you watch the movie Squid Game, I know many of you may have watched this movie, but just one thing to mention, that if you miss the signal, you may die. That is the motto of the movie, and that is the reality we have faced, that
If we miss any of the complication signal, then patient may die. Each and every time patient is going through these complications. And most of the patients are having the neutropenic fever, mucositis grade 1 and 2. But severe vomiting, pneumonia, bacteremia, including bad bugs. There are few patients, including MRSA, Acinetobacter, and multi-drug resistant bacteria. And the growth, GVHD happened in 2 patients among 5 allogenic transplant patients. So this is the Evercare Hospital data. Progression-free survival is 66%. They have done 43 so far up to September, but recently we have seen that they crossed the 50 cases. They have done the major, most of the allo patients in our country, 15 allogenic transplantation. Among them, 4 were haploidentical transplantation, which is a very encouraging and very appreciating data from them. And the CMH Dhaka transplantation activities shows that they also started 2016 up to now 36 allogenic, both auto and allo have been done. And very appreciating is that their all allogenic patients are alive and are in good share. So this is the data of their center. And this is CMH transplant team headed by Colonel Dr. Mosleuddin, and this is DMCH, our team. I must mention that Professor Dr. Bimolangshu De and Professor M.A. Khan, who were the pioneer establishing the bone marrow transplantation in Bangladesh, he was giving instruction, and every day morning round, he was joining with us through Skype or either virtual media. So this is our transplant center, and the first transplant center, it was inaugurated by our ex-late health minister, and he is the now present health minister, honorable health minister. They came to and visit our center several times. And this is Evercare transplant team. They have completed 50 transplants so far, few days back, like 5 or 6 days back. They have a paper news. And due to COVID-19 pandemic situation, which stopped the activity of Dhaka Medical College Hospital, we don't have any transplant patient last 2 years, 2020 and 21. Our activity is totally stopped, but 2 centers are running very good job because they are CMH Dhaka and Evercare Hospital. They are running their activities. Here are some few publications of our centers, including blood advances and other Nature and Bone Marrow Transplantation Journal and ASCO publication. So this was the digital poster which was based on the journey of stem cell transplantation in Bangladesh, and Dhaka Medical College and MGH collaborated, and Mass General Hospital. You can see Professor Bimolangshu De from the Mass General Hospital and Professor M.A. Khan from Dhaka Medical College Hospital, and he is Professor Tom. He is the writer of many books on transplantation, and me was the author of this presentation. So I must have expressed an acknowledgement to Professor M.A. Khan sir, Dr. A.M. Saleh sir, and Colonel Dr. Mosleuddin for their achievement, and for their activities. I am here to tell you about that status of bone marrow transplantation in Bangladesh. So in my conclusion, I must say that hematopoietic stem cell transplantation is a very complex procedure. This is expensive too, although it is less expensive than other countries or neighboring countries. 135 HSCT in Bangladesh so far done, and 80% for autologous stem cell transplantation. HSCT is curative for many hematological malignancies. So we should take this advantage for cure the patient at least. Government sector DMCH, BMT is stopped since 2020. This is very disappointing, but we have to face a lot of challenges like financial constraint of the patient, lack of health insurance, and inadequate funding from the government. Another thing is that we don't have any bone marrow registry, so we don't have any scope to search for the allogenic unrelated donor. So we need it to be developed, and very slow progress in hematopoietic stem cell development in our country. So finally, I will conclude with that, that our Prime Minister and her sister, they are, I wish, it is my desire to draw attention of her to be that on bone marrow transplantation focused, it should be focused more so that many patients, many life can be saved, many young life can be saved through this bone marrow transplantation. And thank you, সবাইকে বিজয়ের 50-এর শুভেচ্ছা। ধন্যবাদ। And happy to take your question if you have any. Thank you.
We'll take questions after finishing all the topics and lectures. Now I'd like to invite Professor Mamunal Mahatab, Division Head, Interventional Hepatology Division, Department of Hepatology, Bangabandhu Sheikh Mujib Medical University, and he will talk on autologous hematopoietic stem cell transplantation in decompensated cirrhosis of liver, experience from Bangladesh. Allocated time is 12 minutes.
Thank you. That liver can regenerate is an ancient knowledge. This is the Greek god of Prometheus. Prometheus was punished by every day an eagle would come, eat Prometheus's liver, and the liver would regenerate the next day. The eagle would come back, and that's how he was punished. So even in Greek mythology, they knew about the regenerative capacity of liver, and that is the basis of stem cell therapy or liver transplantation, whatever you say today. So it has been shown, it has been also been discussed, that if we inject granulocyte coronary stimulating factor, that results in mobilization of bone marrow derived stem cells from the bone marrow to the periphery. And here you can see there's a 40% rise in peripheral stem cell count following GCSF injections. So what is usually expected is that if I give GCSF, there will be mobilization of stem cells and possibly a new liver will be regenerated. This is one of the hypotheses, but possibly this is not the case. Possibly this does not happen with stem cell therapy. What actually happens is that if we inject GCSF, in the bone marrow, there is increased trafficking of stem cells, increased proliferation of hematopoietic stem cells, increased production of cytokines and growth factors, and importantly, reduced apoptosis. In the blood, as a result, we see increased number of CD34 cells and other cells. And what the cumulative effect in the liver is, there is increased regeneration, reduced fibrosis, and reduced inflammation in the liver. And that results in some regeneration or some increase in capability of the liver function. So don't expect that you give stem cells and there's a new liver that is created and the gentleman with the stem cell therapy will start playing cricket or hockey. That does not happen. What happens is that liver function improves because of this cumulative effect of increased regeneration, reduced fibrosis, and reduced inflammation in the liver following administration of stem cells. And there are much publications in the world literature that will show mixed experience. Some will say that it works very well, some will say it works not so well, some will say it works so-so, like that. But a meta-analysis has shown that yes, it does work. The activity or the effect on the liver lasts for 6 to 12 months, not more than 12 months. So stem cell therapy can be considered as a bridge to transplant or to delay transplant or as a therapy for patients who cannot afford transplant either due to lack of transplant facilities or affordability or lack of donors. So in our center, what we do is in BSMM and also in the private sector where we work, we actually stimulate the patients with injection GCSF. We inject 30 IU per day for 6 days. Nowadays, we have changed the protocol. We now inject 60 IU per day for 3 days and more if needed, but usually that is the dose. And we started very slowly and with a step-by-step approach. The first paper that we published, we actually took 18 patients with decompensated cirrhosis of liver and just applied GCSF. We tried to see the safety of GCSF in such patients. There was the concern triggering HCC development, etc., etc. So we did first do a small study to see the safety of the regimen in decompensated cirrhosis. And once we saw that it was at least safe and to some extent efficacious, we did a larger trial which was subsequently published in Hepatology International, one of the pioneering journals in our subject, where we did see survival as well as liver function benefits in a patient with acute and chronic liver failure patients, which is a form of liver decompensation, but much faster liver decompensation. And having seen this success, it is not no groundbreaking paper, but this paper did show that with GCSF injection only, patients with acute and chronic liver failure, which I just mentioned, is an accelerated decompensation of liver, do benefit in terms of quality of life, in terms of improvement of liver function, and to some extent in terms of survival. Then we did another study where we combined GCSF with erythropoietin, and we got slightly better results. So this is using two drugs to first carried out with the cooperation of the hematology department of this medical university on 2nd February 2017. What we did was we injected stem cells, GCSF, and after GCSF injection for 6 days on average, we then collected the stem cells using an apheresis machine and using a special kit that isolates CD34 cells only. So now the question comes that what is the cell count that we are looking at? So we have done flow cytometry in a series of patients, around 50 patients or so in this medical university, and we found that the average count was 7.5 into 10 to the 5 per ml. That was the average count that we got after 6 days of GCSF injection. And when we correlate with the total white cell count, we see that if the white cell count is around 30,000, then the count is like that. So nowadays, we don't routinely do this flow cytometry anymore, but we have the data for at least the first 50 cases. The next question that will come is, okay, you are collecting CD34 cells, you are collecting them in good numbers, whether the cells were viable or not. So yes, in the initial days, we also looked at viability with the facilities used in our university, with the in collaboration with the microbiology department, and we saw that the stem cells that we were collecting were viable. So in the good old days, what we would do is, we would collect those stem cells and then inject them into the hepatic artery. As you know that those of you who attended the morning session today, Central University, University Central Seminar, we had presented our TACE data, transarterial chemoembolization, which is a special technique of treating liver cancers, where we hepatologists go take our patients to the cath lab, we access the femoral artery, then go to the abdominal aorta, and instead of going up into the liver, into the heart, we take the right turn, enter the celiac trunk, then hepatic artery, selectively catheterize the feeding arteries of the liver cancer, and inject lipid and a chemotherapy agent. So we took the same principle, but here instead of injecting the chemotherapeutic agent, we cannulated the or approached the hepatic artery and then injected the stem cells that we had just collected. So, but we always had the in mind that how we could do it better and cheaper, because access to cath lab is expensive and adds cost to the patient, and also radiation exposure, etc., etc. However, we did go on presenting our data in different conferences, both at home and abroad, not only in international liver conferences, but also in conferences of hematology and transfusion medicine in both Bangladesh and in international conferences. And in the meantime, we were thinking of how to improve our findings. By then, we had also actually published our data, collecting stem cells after GCSF injection using apheresis platform, and then injecting the stem cells into the liver through the hepatic artery. And we found that this is no wonder drug, this is no wonder cure, but patients do improve. There's improvement in albumin, improvement in prothrombin time, reduction of serum bilirubin, and improvement of quality of life. But statistically significant improvement of serum albumin level was noted, statistically significant improvement of ascites was noted, which was most encouraging. But I want to make one thing very clear, the patients did receive standard of care plus stem cell therapy. It is not that we stopped all treatment whatsoever and only treated with stem cell therapy. No, that was not the case. They got standard of care as they get in our centers, plus stem cell therapy, and we found that with stem cell therapy, there's improvement in liver function, improvement in quality of life, most importantly, statistically significant improvement in ascites and albumin level, which we thought was a very encouraging outcome. And in the meantime, we were brainstorming how to approach. The next approach was to access the liver in a more palatable way, and we chose the portal vein. because the portal vein can be approached percutaneously using a Doppler ultrasound, and we do so many liver biopsies and FNACs. We know that the liver is not such unstable. Introducing a needle will not harm the liver that much. The concern, and also 80% of the supply of the blood supply of the liver comes from portal vein, and portal venous blood flow is much slower than arterial blood flow. So we hypothesize that if we put the stem cells in the portal vein, the number of cells delivered to the liver will be in larger numbers because the blood flow is slower and more blood going to the liver through the portal vein. The concern was, however, whether this would induce portal venous thrombosis or not. So we started slowly, and it was on 30th August 2018 when we did the first case at a private hospital in Dhaka. Same principle, injecting granulocyte corneal stimulating factor, increasing number of peripheral blood stem cells, collecting CD34 cells using a apheresis platform. But instead of going into the cath lab, taking the patient to a simple ultrasound machine and percutaneously injecting the stem cells into the portal vein. But the entire thing is a non-touch technique. It's a closed circuit, as you can see. The stem cells don't come in contact with human hand or anything in either of the two procedures. And we did publish our data. And what we found was similar to what we got in arterial route administration. Here also, there was improvement in liver function, improvement of bilirubin, albumin, most importantly, statistically significant improvement of albumin and ascites. So this also got quite some media attention, and which is important because unless you have the media backup, these type of innovative therapies can't persist. There will be backlashes and so on. But we did not only stick to that. As I was mentioning in my welcome address today, that we did contribute beyond our discipline. When the Drug Administration of Bangladesh formulated the national guideline for stem cell and regenerative medicine, several members of the society, including me, we contributed to that. And when the international inter-academy partnership, which is a collaboration of Academy of Sciences from all over the world, asked for nominations to develop a statement for stem cell therapy. The Bangladesh Academy of Sciences nominated me, and I was chosen as one of the 12 scientists who actually drafted the statement, which was subsequently published. So this is actually a recognition of the stem cell therapy that we are doing. And this conference is not also the first one. This is the 5th conference that we are doing, and the Honorable Prime Minister has been kind enough to issue a message on each of these occasions, in each of these stem cell conferences, including this one. Last year we were virtual. This year we are back again. We have this every year in December in this very venue. So to summarize where we are today, we are in the very early stage of the ladder. We have only done autologous stem cell transplantation. But the sky is the limit. Someday someone will make artificial liver. That day will also come. Maybe I will see that day, maybe I will not see that day. But the satisfaction is that at least we have started the journey. We may not be able to complete it, but someone will complete it. But the thing is that we started the journey, and this is my very favorite slide, which I quoted this morning in my talk at the University Central Seminar. I would like to end my talk quoting this slide again. আমরা সবাই জানি যে কবিগুরু রবীন্দ্রনাথ ঠাকুর বলেছিলেন 7 কোটি সন্তানের হে মুগ্ধ জননী রেখেছো বাঙালি করে মানুষ করণী। আর বঙ্গবন্ধু শেখ মুজিবুর রহমান 10ই জানুয়ারি স্বদেশ প্রত্যাবর্তনের পর এখান থেকে খুব কাছেই শরৎ উদ্যানে বলেছিলেন কবিগুরু দেখে যাও তোমার বাঙালি আজ মানুষ হয়েছে। So I think our facilities may be very few, but if we try, we can do that. And I will ask you to stay back, because after this, we have one session. There's a keynote talk on BongoVax, the homemade vaccine against COVID by Bangladesh, and that will show that how Bangladesh did become the 3rd country in the world to develop an mRNA vaccine against COVID. And that's a 100% vaccine made in Bangladesh. I very proudly say that is a vaccine made in Bangladesh, by Bangladesh, for Bangladesh and beyond. So please stay back and listen to the talk also. Thank you very much.
Thank you, sir, for your presentation. Now, I'd like to invite Dr. Moshur Rahman Khosru, Associate Professor, Department of Physical Medicine and Rehabilitation, Bangabandhu Sheikh Mujib Medical University. He'll talk on outcome of single intra-articular injection of adipose tissue-derived mesenchymal stem cell in knee osteoarthritis. Allocated time is 12 minutes.
Thank you very much. Very good afternoon. Respected Chairperson, learned audience. I'd like to thank the organizer for giving me the opportunity to share our research experience regarding nanofat transplant in osteoarthritis knee. Before going to my presentation, I would like to pay my humble tribute to Father of the Nation, Bangabandhu Sheikh Mujibur Rahman, on the 5th Victory Day of Bangladesh and 100th birth anniversary of Father of the Nation. And this research presentation is dedicated to the participants, the samples, and all the patients suffering from osteoarthritis knee. From the team, we have nothing to disclose for this presentation. Ladies and gentlemen, you all know that osteoarthritis knee is the topmost cause of musculoskeletal disability. And now it is considered as the osteoarthritis knee is a failure of the joint. Entity, very recent data shows that 7.3% of adult population is suffering from knee osteoarthritis. And there is a variation in rural and urban population. Urban population a bit more sufferer than that of the rurals. And there is a gender variation as well. 2% more women compared to the men are suffering from the osteoarthritis knee. We all know that symptoms of osteoarthritis knee is the most thing is that along with joint swelling, deformity, patient presents with pain. Pain initiates the patients to visit the physicians. And the source of pain is not only from the cartilage degeneration or the joint friction, adjacent tissues, including ligaments, subchondral bone, muscles, tendon, all can contribute to worsening the pain in osteoarthritis knee. And currently available treatment options are from the non-pharmacological to the surgery. There are many steps to follow, but other than the surgery, not all the conservative measures are useful for many cases, even after giving intra-articular viscosupplements. And today's, as the aging process, expected life expectancy is increasing and people's expectation is increasing along with the development of the science, today's patient with osteoarthritis knee expect that we shouldn't have any pain and want to be independent fully, and they want a local solution for this local problem. So what is the hope? In the last decade, cell-based therapies options are coming up, starting from the platelet-rich plasma, subsequently mesenchymal stem cells, hematopoietic stem cells, and so and so. And there are hundreds of evidence supporting that mesenchymal stem cells and bone marrow aspirate concentrates are useful for managing, for improvement of the knee joint functionality as well as cartilage regeneration. There are several systematic reviews as well that mesenchymal stem cell is not harmful, and autologous mesenchymal stem cell has very limited adverse effect in cartilage regeneration for osteoarthritis knee. So what we are thinking that as there are many sources of mesenchymal stem cells, particularly adipose tissues, since US FDA do not approve stromal vascular fraction for the treatment of osteoarthritis knee. And the second thing is that nanofat they advocate to use, because stromal vascular fractions and nanofat, there is a big difference. And advocating this thing, and we wanted to ensure that what is the protocol and how we could proceed. Should we start with stromal vascular fraction, or we should go for nanofat or microfat transplantation? Keeping this question in our mind, we designed a protocol for this pilot study using nanofat for cartilage regeneration in osteoarthritis knee. This research actually funded by the University Authority, and we aimed for to see the impact of intra-articular injection of autologous adipose tissue-derived mesenchymal stem cells on pain, functional, physical functions, stiffness, and cartilage regeneration. We recruited all the individuals following ACR criteria to confirm the diagnosis, and we also look for the Kelgan-Rollin radiographic grades to identify the right cases. And we assessed all the cases with high-frequency ultrasound. We excluded the patients who received viscosupplement, steroid injections, or PRP, or any source of stem cells in last 6 months. We excluded all inflammatory infective patients, including rheumatoid arthritis and tubercular arthritis. We also exclude the local eczematous skin and skin infection patients to prevent joint infection for, during this transplant of nanofat. We included a total 30 number of patients with knee osteoarthritis, and we randomly divided into 2 groups, case and control. The both groups receives nice protocol standard care for knee osteoarthritis, and the case, the experimental group received single dose of autologous adipose tissue-derived stem cells. We mentioned this, the nanofat, and 3 ml of activated platelet plasma. Platelet plasma was activated with calcium gluconate, 1:9 ratio, and we tried to harvest the adipose tissues according to the guideline by cartilage regeneration societies, and the tissue was harvesting using Tamsuline solution collected manually and processed with collagenase as well as manual adapter tissue breakdown mechanism, and therefore the nanofat was filtrated using nanofilter, and finally activated PRP was mixed with adipose tissue, and therefore injected without storing into the refrigerator. We tried to measure the outcomes in terms of pain at 2, 12, and 24 weeks, along with the functional, physical functions with omega scales, and before and after 6 months or 24 weeks of transplantation, we measured the cartilage thickness. So what we found? More than 50%, almost 2/3 of the patients are female, and the participant distribution regarding gender, mean age, BMI, and grading of the knee osteoarthritis were insignificant during enrollment. And after 6 months, we found that there is a clear difference between case and control groups improving pain from 5.6 on VAS scale to 1.6 on VAS. And compared to the control 5.6 to 3.8. What does it mean? Conservative management also effective for knee osteoarthritis management, but there is an added benefit of injecting nanofat for managing osteoarthritis knee. Same scenario, same outcome was also observed in physical functioning. Initially, physical functioning score on OMAC was 39, and after 6 months, the score declines as low as 6 in case of experimental groups, and on the other side, it is as high as 20 in control group. During enrollment, the mean cartilage thickness was 1.9 millimeter and 1.96 millimeter in case and control respectively. And after 6 months of the trial, the musculoskeletal ultrasound scan shows that 1.9 millimeter thickness difference was observed between the groups, where 0.14 millimeter of cartilage thickness was increased in nanofat group compared to the control group, where 0.04 millimeter was declined. So therefore, there is a difference between about 0.2 millimeter of cartilage thickness at 6 months. This result supports many other studies conducted in other parts of the world. And the injection of intrapatellar fat-derived autologous stem cell also shows the similar efficacies in osteoarthritis knee. Multipotent mesenchymal stem cell from the adipose tissue, blood, including umbilical cord, Wharton jelly, have immunomodulatory, reparatory, and anti-inflammatory potential and effectively healed degeneration cartilage. There is a limitation of our studies that the RCT was conducted with a little number of sample size, and we did not compare the effect of single versus multi-doses of nanofat, and we did not evaluate the dose-dependent effect of adipose tissue mesenchymal stem cells on different stages of articular degeneration. But there is a strand of the study that we wanted to see whether cost-effective single shot of stem cell preparation healed degenerated articular cartilage in knee osteoarthritis. We set a big goal with very limited resources, but we are trying and hoping that we will overcome the limitations that we are dealing with. My take-home message is that intra-articular injection of autologous adipose tissue mesenchymal stem cell could provide symptomatic, functional, and ultrasonogram depleted improvement of knee osteoarthritis. Hoping that in future, it is expected that stem cell therapy will replace many surgical treatment options among patients with musculoskeletal disorders. So we formed a multidisciplinary team to approach to conduct this research, and we are moving for the phase 2B trial using adipose tissue stem cell trials. So we have physiatrists, we have musculoskeletal sonologists, we have plastic surgeons with us, and along with internationally well-reputed regenerative specialist, Professor Michel Chekhov. He is guiding us. Thank you very much for patient hearing, and once again, we want to say that Joy Bangla.
Now the session is open for question and answers. I'd like to invite questions from the audience. I think that there is no question. So I'd like to invite Dr. ABM Adnan from Cox's Bazar Medical College, co-chairperson of this session. Please comment on this session and the speakers. Good afternoon. The chairman of the session, Professor Selimu Rahman sir, and my dear learned audience. We have just heard 3 presentations. First one by Professor Mafuha Akhtar on hematological malignancy using stem cell therapy in hematological malignancy patients. Professor Mamunal Mahatab on regenerative and interventional therapy in liver patients, and finally from Professor Moshiur Rahman Khosru. Thank you all the presenters for their very exciting presentations. As a subject, regenerative medicine is fast growing and its applications are becoming more and more helpful and prevalent around the world. And I believe we have the ability in our country to expand this knowledge in our patients. And I would like to ask all the personalities, the concerned policymakers, to extend this new approach around the country, in all parts of the country, including in my institution, where I'm working at present. And with this, I would like to thank again to you for your patient hearing. Thank you. Thank you, sir. Now I'd like to invite Professor Selimur Rahman, former UGC professor and former professor, Bangabandhu Sheikh Mujib Medical University, chairperson of this session, to say comment on this session and these speakers.
Thank you very much, all the 3 brilliant speakers for their brilliant deliberation. The first deliberation, all the 3 speakers have shown the utility of different utility of stem cell therapy. The first speaker very nicely has elaborated the utility of bone marrow transplant on aplastic anemia and the bone marrow malignancy. The second speaker is very elaborately and very nicely the experience of their team about the use of a stem cell in liver disease. In this liver disease, we have also some little experience, and my impression is that this stem cell therapy in liver disease will be a very good modalities in future. You have mentioned, you have noticed that the second speaker has mentioned that this is not a replacement therapy for the liver transplant in severe decompensated liver disease. This is a bridge between the transplant, a bridge treatment in between the transplant. So there may be a misconception, this is the alternative therapy for liver transplant. This is not. This is the misconception, makes a wrong idea about the treatment of stem cell therapy. The third speaker is also very nicely elaborated another mode of treatment of stem cell in arthritis. So I congratulate all the 3 speakers, and my advice as a senior person to the junior speakers to be specific in time. And to be very specific, they should finish their speech in time, otherwise people becomes very, they do not like the talk, and এটা ঝুলে যায় আমি বলবো সেজন্য I have seen in foreign countries they stop the mic after the scheduled time, giving a warning. So I request all of the younger speakers to be in time in next deliberation. Thank you.
Thank you, Professor Selimur Rahman sir, for your nice comments. It's time for crest distribution. I would like to request Professor Selimur Rahman sir to deliver crest to all our speakers. Namely, at first Dr. Mahrufa Akhtar will receive crest from Professor Selimur Rahman. Professor Selimur Rahman will deliver crest to all three speakers. At first, Dr. Mahrufa Akhtar. Next crest goes towards Professor Mamun Al Mahtab Shopnil. Next crest, Professor Mamun Al Mahtab Shopnil, then Dr. Mushiur Rahman Khushru. Now I would like to request Professor Mamun Al Mahtab Shopnil sir to deliver crest to our honorable session chairs. Professor Mamun Al Mahtab Shopnil sir will deliver crest to Professor Selimur Rahman. Now, Professor Mamun Al Mahtab Shopnil sir will deliver crest to Dr. ABM Adnan. This is all about our scientific session 2. Mamun Al Mahtab Shopnil sir will deliver crest to our honorable moderator, Dr. Sheikh Mohammad Noor Alam Dew, Associate Professor, Department of Hepatology, Bangabandhu Sheikh Mujib Medical University. Dr. Sheikh Mohammad Noor Alam Dew sir is receiving crest from our honorable teachers. This is all about our scientific session 2. We are now going to our keynote lecture, scientific sessions 3. This session will be moderated by Dr. Muhammad Abdur Rahim. I would like to request him to come over the dais.
Pointer, no?
Pointer, right.
Huh? Why to do that? Duplicate.
Sir, extend dile sir presentation view ta amader okhane jabe. আসছে চারে আসছে
কেন
আসে নাই ছিল কিন্তু
কিছু আসে নাই
এটা চার্জারের এটা তোমার সাথে লাগবে না
এখন কি বলেন স্যার পেন ড্রাইভ আছে কপি করে দেওয়া যাবে
আমি যেটা দিচ্ছি
একটু ওয়েট করেন স্যার আসবে আসবে স্যার জি
পুরানো সিস্টেম আপনি কথা বলেন।
Good evening. We are at the end of this seminar, today's seminar, second Bangabandhu Stemcom 2021. The last session, this is the last session. In this session, the chairperson of this session is Dr. Shitesh Basar, Professor, Department of Pharmacy, Dhaka University, Professor Dr. Harisul Haq, Professor of Cardiology, Bangabandhu Sheikh Mujib Medical University. I will request both of the chairperson to take their chair. In this session, the topic is Mongovax, vaccine of COVID-19 by Bangladesh, for Bangladesh and beyond. The speaker of this topic is Dr. Kakon Nag, CEO, Globe Biotech. I request Dr. Kakon Nag to deliver his speech.
হ্যাঁ দিচ্ছি দিচ্ছি
বন্ধ করে ফাইলটা বন্ধ করে আচ্ছা
স্যার কোথায় আছে এটা স্যার হ্যাঁ স্যার এটার আগের ফাইলগুলো
সরি
ঠিক আছে আস্তে আস্তে কোনো সমস্যা নেই।
দুইটাই এটা একদম র্যান্ডম
আসছে
এদের জন্য সমস্যা আছে যে আমারটা
একটু আগে তো সব চললো ঠিক করে
ওয়ান ইয়ে আছে ওয়ান আছে
এখন পাচ্ছে